Yes, who's first? Who's going first?
I'm going first.
You go first? Okay.
Yeah.
I'll just
I set the trap for him.
yes. What? Should I mute this or?
Are you on mute?
No, already.
No, I'm not on mute.
All the stuff.
Great.
We have the people to just keep their Chrome or tab or everything open. They don't need to scan it every time. They don't need to pull the codes every time. Whatever they have open.
Keep the app open.
Yeah,
The slider
the
app.
questions will. Yeah, the questions will.
Okay, very good. Housekeeping announcement. Dr. Ho has arrived on time. No. Keep, if you can, if you have the app, just keep it open. If you can, the Slido app. It makes apparently the whole system running much smoother. So we're going to start the first afternoon session. And again, there's been a major change in the AHA guidelines on atrial fibrillation. And Luigi Di Biase, who's a professor of medicine and assistant director of electrophysiology, also extremely well known internationally, will give us an update. Luigi is a great colleague. And when you ask him, should we up late, there's only one answer usually.
Thank you, Uli, and every organizer and co-director, and my pleasure to be here. And, last year we had a debate with Uli, so it's important that we follow up on the debate. And these are my disclosure, important for everybody to see. But before that, before I start the presentation, let's start with the app that you should have, okay? And I have a few questions for you. The first question is, in a patient with the 66-year-old patient with heart failure and reduced ejection fraction on GDMT, on anticoagulation, that presents to the emergency room with the AFib with RVR, documented by his CRTD interrogation, with an AFib burden of 27%. According to the new guidelines, or to the guidelines that you remember, what should you do, or what do you do in everyday practice? A rate control strategy, a TE with only 2E and not 3, and a cardioversion with amiodarone. You recommend catheter ablation. You recommend a cardioversion without antiarrhythmic drugs, or since the patient has an ICD, CRTD, you proceed directly with AV node ablation? Please vote. So again, this is a patient, come to the emergency room, one of you, the cardiology fellow or the MP or the PA or the heart failure specialist goes down, patient has a CRTD, ICD interrogation, 27% AFib, patient is fast AFib already on anticoagulation. This is not his first episode, of course. So will you go for AV node ablation, for T, cardioversion and amiodarone, T cardioversion, no amiodarone, catheter ablation, rate control? Do we have the vote? Okay, so the number of people that will perform a catheter ablation is 26%, and another 26 will do rate control and cardioversion and amiodarone 41%. AV node ablation directly 3%. Very good. Let's see what the guidelines say then. Second question. Now you have another patient. This patient is 74-year-old, has an heart failure with reduced AF on the GDMT and oral anticoagulation, present to the emergency room with new onset atrial fibrillation. So different from the prior one that has a burden and many episodes. This is a new onset. Would you do a rate control strategy? Would you go for cardioversion and amiodarone, catheter ablation? Same as before. Same question as before. Please vote. And these are common patients that we see every day in practice, and I think it's important that we discuss. Okay, let's see the answer. So, rate control strategy in the first episode of atrial fibrillation. That tells me a lot. Shock and amiodarone, and from 26% ablation to 15% ablation. Very good. Let's go back to my slide now. So let's go. I'll start from what we finished last year. So before we decide what to do for this atrial fibrillation, I agree with all the heart failure doctors that we need to have the patient on optimal medical therapy. We heard from the presentation today, from Dr. Yancy, everything we have to do. And below you have the old guidelines. You see that amiodarone in class 1 and ablation is only after the failure of the medication. In class 2A is a first line, and in class 1 only when you suspected tachycardia-induced cardiomyopathy. But none of the patients I showed you were proving that. And ablation was considered only after the failure of the medication, as you can see in the lower part of the slide. But we concluded last year saying that the only music I like to hear in the EP lab is sinus rhythm. And not only I like this as a music, I like this as a concept. I do believe in sinus rhythm therapy. So I believe the sinus rhythm is better for the patient, no matter what you have been told or what you believe. And last year, we tried to brand Uli here with me. So we have created the MonteHeart approach for this patient. And we call attack the castle, because the two major trials that are there about atrial fibrillation ablation in heart failure is the ATAC trial, which we conducted, and the Castle AF trial that you probably know. Now that I told you what last year we debated, I have to say, I can conclude the presentation with the new guidelines that they come out, because Uli attacked me and you prove me that only 15 and 26% of ablation is requested in this patient. But what the guidelines say? So the 2023 atrial fibrillation guidelines, not ablation guidelines, this is the circulation paper, this is the JACC paper, prove this indication, and let's read together. In patients who present with a new diagnosis of atrial fibrillation, reduced EF and AF, arrhythmia-induced cardiomyopathy should be suspected, and an early and aggressive approach to AFib rhythm control is recommended. but the patient I show you were not this one. The patient I showed you is that inappropriate patient with AF and reduced ejection fraction who are on GMT with reasonable expectation of procedural benefit. Catheter ablation is beneficial to improve quality of life, symptoms, ventricular function, and cardiovascular outcome. And what is the class of indication? Is a green with a level of evidence A. So I want you to know that the guidelines have changed and we should do more ablation than what you have answered today in the room. Inappropriate patient with symptomatic atrial fibrillation and heart failure and preserved ejection fraction with reasonable expectation and of benefit. Catheter ablation can be useful to improve symptom and quality of life. And this is in class 2A. So even in patient with heart failure and preserved EF, we don't have class 1, but we have an indication that is less strong than the other one. After the guidelines of atrial fibrillation, we have published, we had the consensus document on catheter ablation and surgical ablation of atrial fibrillation. The 2017 has been updated with the 2024. I've been part of this document as well. And in this document, again, catheter ablation of atrial fibrillation is beneficial in first-line treatment of symptoms with patients with recurrent paroxysmal AFib, but is reasonable as first-line treatment and is extremely important in patients with heart failure. And you can see here that the trial that have supported that, we will go through that. But as you can see, is a green as well, advised to do. Now, I have to reconvince you about why the guidelines have changed and why. And it was the task I've been given. From heart failure trials, and these are 1998 trial, is the SOLVE prevention trial, you can see that in patients with heart failure, total mortality, heart failure death, and sudden cardiac death are all affected by atrial fibrillation. So it's very clear here. And when you look at which patients are more affected than others, these are the more advanced heart failure patient, class 3 and 4. There is no statistical benefit of the sinus rhythm here, but there is a strong statistical benefit in this. So the patients that are in New York Class Association 1 or 2, which are the healthier, the one that can do an ablation, are the one that the most benefit from sinus rhythm. Therefore, we should absolutely do everything we can to maintain and to put them in sinus rhythm, the music of my EP lab. Second message is you try to wait and you send us the patient too late. When 26% said ablation. Why? Because you shock, you rate control, then the patient come back and then come back and then come back. After the fourth admission, oh, let me call EP now. But ablation is not salvation. We want to do the procedure earlier rather than later. So timing matters. We have evidence on New England Journal of Medicine that early rhythm control therapy in patients with atrial fibrillation is extremely important. And we have a relative risk reduction of 21% when we use this strategy. Now, you can use this strategy with medication or with ablation, but we have randomized study proven that ablation is better than medication. So you may go for your conclusion, and 21% relative risk reduction of a composite outcome of death from cardiovascular causes, stroke, hospitalization with worsening of heart failure or acute coronary syndrome is pretty important to me. We also have data on New England Journal of Medicine that early ablation better than late ablation. This is a study in Canada by Dr. Andrade. You can see ablation versus medication when you intervene early. So early ablation better than medication in freedom from AFib. And this is from Cleveland Clinic, Dr. Wasney. Again, New England Journal of Medicine. And these are 2021 papers. And timing matters because AFib is a progressive disease. When I speak with my patient, I say AFib is like cancer, early diagnosis, early treatment. When you have initial stage of atrial fibrillation, it will progress. And we have data that show that AFib progress from paroxysmal to persistent. Therefore, if you intervene early, you do a better job. But we also have data about what happened to the patient if you wait. So this is a 4F plot of the percentage of AFib progression. These are all studies that look at this, divided in two groups, general population and AFib ablation. And you can see here the weighted progression of AFib as a function of follow-up duration. You can see how the general population in blue is completely different for the AFib ablation studies. So it's very important that you not only want the freedom from AFib, but you want to block the progression. So if you start with a medication that is weaker than the ablation as a therapy, you will have a worse progression of the disease. So as cancer, in my analysis, you know, if you do an early intervention, a small lump is removed, it's easier than a mastectomy with probably lymph node resection. It's very simple in this way. And when you look at the mortality, you can see that when you look at the mortality by AF type, you can see that there is a difference between patient in red, in persistent atrial fibrillation, versus patient in blue with paroxysmal atrial fibrillation. So if you allow the persistent atrial fibrillation to come, you will probably have a worse outcome to your patients. We have trials that look at the progression with ablation. This is the ATTEST trial done by Dr. Cook with radiofrequency energy. And you can see that ablation is better than medication. This study was published only on Europace because they had to stop the trial and they do not have enough power to say what they say. But I'm showing you, and you can see here the freedom from atrial fibrillation is clear when compared to medication, but the progression is also clear here. But we have a bigger trial that was presented last year at AHA on the New England Journal of Medicine. Basically, again, atrial fibrillation, early ablation versus medication, and look at progression. 383 patients were randomized to medication versus ablation, medication, flecainide, propafenone, sotalol, dronedarone, amiodarone, and whatsoever. Primary endpoint, progression to persistent, 75% reduction in progression. So you block the progression of your atrial fibrillation with an early ablation. Confirmation that freedom from atrial fibrillation is better with ablation than medication. But that has been proven in many trials, just confirmed here. Also, better AFib burden and improved quality of life with ablation. And more interesting, better healthcare utilization, less emergency room department visit, less hospitalization, less cardioversion. So this is extremely important. When you look at safety, I like this slide. You look at the complication. Ablation had 1 death, 3 cases of self-limited fretting nerve palsy, and 2 pacemaker implantation. How about the medication that we give so easy? Medication has 1 death as well, 2 cases of Y complex tachycardia, 2 heart failure exacerbation, 3 acute coronary syndromes, 3 neurological events, 2 strokes, 1 TIA, 3 syncopal events, 4 pacemaker implantation. So when you are selecting your choice in therapy, if you feel that the ablation is more dangerous than the medication, I think you're wrong. And we have to think about this. And this is the conclusion of the trial. We have only one randomized controlled trial about AV node ablation in patients with heart failure and reduced EF, but I'm a co-author here, was a very old paper. But again, it improved PVI versus AV node ablation. You see improvement in EF, 6-minute walk, and quality of life. So the guidelines have changed based on a lot of this information. What was very weird in the guidelines was not only that from 16 to 20, we stay AFib in class 2A despite many trials. What I questioned in the old guidelines was the use of amiodarone in heart failure, because amiodarone, you can see here, increase the mortality in my mind. This is our paper, the ATAC. You can see the mortality rate, 18% versus 8%. We all know that mortality, amiodarone has a lot of possible side effects, bradycardia, thyroid toxicity, pulmonary toxicity, especially when used for too long. And when you look at, comparison with placebo is also extremely positive. And actually, from heart failure trial on ICD, we know that placebo and amiodarone increase mortality when compared to ICD. So I'm just telling you that amiodarone has proven in heart failure trials to be not the best drug to be used, but it is the drug that we all use a lot. And the cousin of the amiodarone, the dronedarone, that was supposed to be the non-side effect drug, actually in heart failure patient cannot be utilized due to the increased mortality and stopped in the PALLAS trial. So the evidence that ablation works start in our paper 2016, where we compare ablation, all patients with CRTD or ICD, comparing ablation versus amiodarone. We had much better outcome with ablation. It is true that the type of ablation and the experience of the center performing the procedure matters. You can see that the success rate went from 29% to 61% according to the volume of the center where the ablation was performed. But in our trial, without having the power to do that, we show that in patients that have no recurrence, despite this was achieved with amiodarone or with ablation, you have the improvements. If you have the recurrence, you don't have the improvements in EF, 6 minutes of Minnesota. So sinus rhythm matters again. You want to achieve sinus with amiodarone? I wouldn't do that, but you need to achieve sinus. And that's the message of our trial. After our trial, a study designed on mortality was published. This is a Castle AF, and you can see a relative risk reduction in death of hospitalization from worsening heart failure, death from any cause, and hospitalization from worsening heart failure. All 38, 47, and 44% risk reduction. Now, if you want to dig into it, where is the best benefit? Well, when you look at the NIA class, it responds to what I told you before. The best is when you select patient with a lower NIA class than a higher NIA class. You can see benefit on that and cardiovascular hospitalization, and you can see there are differences between the New York Class Association. There is a difference based on the impact on LVEF. We have more trial, the Cabana trial, sub-analysis of heart failure, again, extremely positive, as you can see here, blue ablation, blue medication, red ablation in heart failure patients. We put together a meta-analysis here with cardiology fellow, and all-cause mortality, change in LVEF, and atrial arrhythmia were better. And this all from 8 randomized controlled trials. We have some data about end-stage heart failure with atrial fibrillation. The Castle HT study, I learned from my colleague here of heart failure that too many patients were on beta blocker in this trial to call this end stage. Not many patients were wean off pressor. So I think this trial actually confirmed that in patients that are not in end stage heart failure, they benefit very well from ablation. Now, if you want to dig and say, see, I still want to do it, but I want more. Can you dig more? Yes, you can do an MRI, and the patient that are LGE positive do worse than LGE negative. So if you have another cardiomyopathy that is not just the common one, probably you don't do well. We spoke about the NIA class. Can you look at ICM and non-ICM? Maybe there's a difference there. There are 2 negative trials. One is the AMICA and one is the RAFT, but actually the RAFT is going to be published probably in the next 6 months about extension of follow-up. It's just a matter that they didn't wait enough. And actually the follow-up is coming and it's positive as well. So it's a matter of how long you wait to see the benefit. Also, we have data about the burden of atrial fibrillation. And when you have a reduced burden, probably, and this is what I challenge you, is if we do ablation, we reduce the burden of AFib, even if we don't achieve sinus, maybe we reduce the pressure of the patient by going transeptal, similar to some of the technique and device that are there in heart failure that try to perforate the coronary sinus. Probably reducing the pressure, going transeptal, has a benefit on heart failure patients. And therefore, despite no sinus rhythm, they still do better because the transeptal adds a pressure benefit to the patient. We don't have a lot of data on the heart failure with preserved EF, but we have data that in these patients, sinus rhythm matters. These are some heart failure patients. You can see that more than 50% of heart failure with preserved EF have AF, and only 8% receive rhythm control therapy. So spironolactone and sacubitril did not prevent or reduce the level open of post-randomization AF in this trial. Can ablation have a favorable effect in this other heart failure patient? There are still some paucity of data, but we know that atrial fibrillation is not the way this patient it has an impact, because this patient, they die not because of sudden cardiac death or aborted cardiac arrest, but they die because of pump failure and mortality. And when you look at the mode of death in these patients, you can see that the atrial fibrillation is an independent variable that is impacting the quality of this patient. So it's important because the pathophysiology of this patient is there, and I think sinus rhythm is very important. And also look at the impact on BNP. These are patients no atrial fibrillation, and atrial fibrillation, look at the impact in the how goes exponentially high the BNP when you have atrial fibrillation. These are not ablation studies. These are, heart failure studies. We only have one randomized trial looking at this with only 20, at the end, only 31 patients enrolled, but all the variables are improved with ablation. I don't think we have enough data for this. We can do peak, you can do Minnesota, peak relative, and the 6 months. Ablation better than medication, and you can see that here, it's always the sinus rhythm, the one no arrhythmia recurrence that do better, although based only on 8 patients. So very small study. We have a study that I'm in the advisory board, the TAP-CH Shift trial that is ongoing, where we're going to look at this other heart failure with preserved ejection fraction. We also have a new energy source, which is the pulse field ablation, that differently from radiofrequency will not give stiffness or atrial stiffness to the heart, because it's a different energy. And we have this paper just published here where we did PFA versus RF, and we have a better outcome in this patient that usually have, elevated pulmonary hypertension. And you can see that MPAP at baseline and follow-up, there's a difference between pulse field ablation and radiofrequency. New ideas for research. So we go to the conclusion, the guidelines have changed for heart failure patient with atrial fibrillation, attack the castle, and only listen to the monitor with sinus rhythm. Thank you very much for your attention.
Ablation important.
Thank you.
Question is, in heart failure patients, what would be your limit of left atrial size if, let's say, 2 times the ablation had recurred? That is one question. Second question, can you comment on the entity atrial cardiomyopathy and how much it would affect ablation?
So these are extremely important questions. The first answer for you is, this is why we need to intervene early. Instead of, I think the heart failure doctors keep the patient too long before asking our intervention. And then this allow the AFib to progress, the left atrium to enlarge, and it becomes more difficult to do ablation. The limit I have, it depends on which technique you use for ablation. If you do PVI only in an enlarged left atrium, the procedure is useless. If you do PVI plus posterior wall and other area, the procedure is helpful. My limit is 5.6 centimeters. More than that, the procedure is too late to do the ablation. If you do between 5 and 6, you have to do an extensive ablation like an endocardial maze to achieve a good outcome. Now, the benefit in heart failure, in my mind, is not only given by the sinus rhythm, but is also given by the reduced pressure that we do by doing that. So first question is early intervention. You need to avoid the patient to enlarge and progress. And that's, you're not gonna have that problem. If you really need to select when, no more than 5.5 to 6 centimeter left atrium. At least with current technology. We have PFA and we have to evaluate that. Yeah, again, that study proved that if you have scar in the posterior wall, or if you have remodeling, you cannot limit the procedure to isolation of the pulmonary vein. I always like analogy. It's like if you have cancer, if you have cardiomyopathy, you cannot just remove the breast and don't take care of the lymph node. So if a patient has progressed and has a scar, an atrial cardiomyopathy, the ablation only of the pulmonary vein, that is the cornerstone, will not work. In patients like that, you need to be more aggressive and at least extend the lesion set to the pulmonary vein, the posterior wall, and sometimes more than that.
Really a great talk. I really enjoyed that. I have two questions for you. I have two similar questions. The first one is, when you wouldn't do it, where is the place where you say, you know what, that's permanent one to make a sense? The second one, I'm a surgeon, and we always have patients with atrial fibrillation at a time of procedure, and the current publication shows that the surgeons are really restricted in the ablation therapy at the time of procedure. To prolong the procedure for like 10 minutes, I think on this. But still, we are very restrictive, and our EP guys are the same. It's typical not, don't do that if they have like more than 5.5 centimeters away side. So I would really, I'm interested to hear your thoughts on that. And where's the point where you say, even as a surgeon or as an EP?
So let's start with the second question. The new guy.
Just to repeat the question because on Zoom.
Okay. So the second question was, if you are a surgeon and you are doing a procedure, a surgical procedure, and patient have atrial fibrillation with an enlarged atrium, should you do it or not? The just released document with the surgeon say that if you are doing an operation and you are there and you have atrial fibrillation, you should do the ablation. And then coordinate. Unfortunately, some centers are better than others in doing the ablation based on the experience of the surgeon, based on the personal, you know, it's like cardiology. I'm an EP and I don't know well heart failure, and the heart failure don't know well EP. The same is for the surgeon. There are some surgeons more pro ablation, there are some surgeons less pro ablation. So the outcome differs. But you all surgeons have a relationship with an EP. I think if you're doing surgery and the patient have atrial fibrillation, you have to do it. And then most likely, because they do blinded, you will need an EP doctor that will go there to touch up later on for flutter, for recurrence, when is the case. For the surgeon also, yes, if you have more than 6 centimeters, it's probably not the case. So when I don't do the ablation, the second question is when I will turn a patient down. Well, when the New York Class Association, when the patient cannot lie flat on a table for 2 hours, I will not do the procedure. When, for sure, when the patient is, the age is a limiting factor, but we all know that there are some 85-year-old patients that look 75 and there are some 85 that look 95. So it's, you really need to look at your patients. An atrium more than 6 centimeters, I probably would not do.
That was really terrific. So the reason we did not have a debate this time is because I don't like to lose. But I really think over the past few years we have discussed this topic, and I have to say I'm usually skeptic. But to me, as I was listening to you, extremely convincing. The guidelines are here. It's to me like ANI and ACE. If anybody still initiates an ANI in HFrEF as a first line, despite the class 1 recommendation, it's just wrong. And the second patient, I think, the one with the new onset, I propose, and this will conclude this talk, that we do a quality project here at Montefiore. Look at admission with atrial fibrillation that's allegedly new and see how many patients go home without a cardioversion. Because this would be against current class one guideline recommendation. There's going to be a quality project without IRB unnecessary. So
Absolutely.
we'll do this together.
Thank you. I completely agree. I think we have gone like in a paradigm shift because we start with the ablation, no ablation, ablation after the failure of medication, ablation as first line therapy outside our failure. I think we have data enough to go for medication after the failure of ablation if you don't want to re-ablate the patient. And I think the data support that. I think in the next guidelines, we will see this shift because the new technology, the way we can do the ablation today has evolved in a way that the procedure are at least at the same safety of the anti-arrhythmic drugs.
Outstanding. Thanks so much. Join us up here. So now we essentially finished one part of the meeting where you've been everyone up to date on the standard of care, medicine, the ablation, all of that. So now we're entering the next phase. What can we do investigationally when everything has been applied, but the patient is still not well? So Connie, I'm going to just what in the last session, we'll begin with transient heart failure.
Okay, switching gears.
Which is being conducted here at
Okay, thanks. Thanks, everybody. As always, we'll start off with a case. We have a 72-year-old male coming in with shortness of breath. He has a lot of risk factors for HFpEF, hypertension, diabetes, and paroxysmal AFib. And I'm happy to report that he's on almost triple therapy, two out of 3 pillars, except for the Spiro. He's noticed this for the past couple of weeks. He's getting fatigued, mostly on ambulation. So we start with an echocardiogram. And of note here is preserved ejection fraction, large left atrium as suggested by this last view here, and even on the parasternal long axis. So what is HFpEF? And we've heard a lot about this from Dr. Shin this morning about some of the ways we can use to diagnose this. But it's, in my mind, it's really the symptom of dyspnea and exercise intolerance that's the cornerstone of this diagnosis. And that's usually how they come to attention. You have evidence of abnormal cardiac structures, large left atrium, LVH. You can have congestion by exam, and the LVEF is over 50%. And just to hone in a little bit about this, it can be also hemodynamically defined as a wedge pressure that's greater than 15 at rest, or with an exercise wedge pressure that's greater than 25. So let's shift to our first audience response question. The following is true of HFpEF. A normal wedge at rest excludes HFpEF. Newer therapies like ARNIs and SGLT2 inhibitors have led to improved survival. Patients with HFpEF generally have much better prognosis than HFrEF patients, and management guidelines thus far have focused on treating underlying contributing symptoms such as hypertension and diabetes. So we went through some of this morning. Let's see how much we remember after lunch. We got about 33 responses. Okay, so split. I love it. So newer therapies like ARNIs and SGLT2s have led to improved survival, or management guidelines thus far have focused on treating underlying contributing symptoms such as hypertension and diabetes. So as you'll remember, there was a lot of yellow and orange boxes, 2A and 2B recommendations for ARNIs and SGLT2 inhibitors. And the endpoints of those trials were combined endpoints, mostly led by hospitalization. So there has yet to be isolated survival data with HFpEF in any of these therapies. So I'm glad that nobody fell for the normal wedge. We can move on to the rest of the.
When you go back to his life, I'm sure you what was the reason?
Okay.
What is HFpEF? It's unclear. You're still studying it, no? The patient was an age population with non-infection.
Should have Should have thrown the ablation response in there, yes. Yes, I stand for, I always go after Dr. DiBiase and I have to change my slides and after I hear him talk. Okay, so options to treat HFpEF, we talked about this, you know, the yellow, the orange and yellow, you know, the colored recommendations. But there's a dearth of options here. We don't really have the thing that really can change people's quality of life and mortality. So that's where the door opens for transcatheter therapies and focusing on this key hallmark of elevated left atrial pressures, not just at rest, but certainly with exercise. So I don't know if anybody has heard of this or recognizes this. This is Ludenbacher syndrome. And this is kind of the first inkling of why left atrial shunt therapies were explored here, is that this is a classically used to describe the presence of rheumatic mitral stenosis along with an ASD. And what was noticed early on is that patients that have these two concomitant lesions actually fared better to a certain point. Their survival was longer than those with just isolated lesions. And that only lasted, you know, to a certain time. Eventually you'll get a heart that looks like this with mostly RV enlargement and probably Eisenmenger's physiology and shunts going the opposite way. But it was noted that initially patients felt pretty good. And there's a lot of questions that we've been trying to explore since then. It's what's the optimal size of this shunt? What is the optimal timing of the shunt? You obviously don't want to do this when there's RV involvement and almost too late. Where do you want to put the shunt? What's the mode of the shunt? And this can't possibly be for everybody with HFpEF. At what point, at what phenotypes would benefit the most from this intervention? So that's where this crowded room comes in. We have a lot of different players in the market now looking and trying to answer these very questions. We have the first three here, which involve a direct implant of a device, a shunt device, through the interatrial septum. Now you can see that the size differs in all of these different devices. We have anywhere from 4 millimeters to 8 millimeters, and this kind of gives you a flavor of, we don't know yet what is the optimal shunt size here. But they all have in common the fact that they're left atrial to right atrial shunts, direct interatrial punctures. Then we have the class of direct interatrial coring without placement of an implanted shunt. So these are just either radiofrequency or cutting catheters or coring catheters that create these holes of different sizes, anywhere from 6 to 12 millimeters. And then we have the novel kind of approach of a left atrial to coronary sinus shunt, which preserves the interatrial septum at 7 millimeters. And we'll talk a little bit in detail through each of these modalities to create the shunt and focus in on what data we have now. So most of you all have probably heard of the Corvia trials, which is the largest shunt trial to date. And it focused mostly on HFpEF patients, so preserved EF or mid-range EF with an EF of over 40%, looking for that exercise wedge pressure of over 25. Very large trial, 626 patients, randomized, sham controlled. So half of these got a sham procedure. And the results were somewhat disappointing in that there was a significantly more major adverse cardiovascular and cerebral events in the interventional group. And overall, there was really not much benefit of the Corvia device compared to sham controlled trials, sham controlled devices. We weren't done with the direct interatrial shunts. So if you guys, anyone saw the late breaking trials from the ACC a couple months ago, it was probably 2 months ago now, you've heard the Relieve HF data. So this is 508 patients, placebo-controlled again, randomized trials. And this was a sicker population. They took HFrEF and HFpEF patients. And the primary endpoint was all-cause death, heart failure, hospitalization, need for LVAD, worsening events, change in KCCQ score. And overall, there was no difference in outcomes between the sham controlled group versus the implant. There was, however, some really important signals that were noted, that in the reduced LVEF population, there was a 45% decrease in cardiovascular events. In the HFpEF, or greater than 45%, greater than 45%, there's actually a 45% increase in cardiovascular events. So why is this? What this highlights again is that we don't know the phenotype that this would benefit. And then, you know, there were several interesting hypotheses as to why this happens, and most had to do with right-sided diastolic function, unable to accommodate the flow, and perhaps that's why HFpEF patients did worse, because HFpEF is a biventricular phenomenon versus just the isolated LV dysfunction patients. But, you know, I think the important thing to take away from this is that maybe all heart failure patients are not the same, and we're still in the process of discovering exactly who this may benefit. So I've kind of answered my own question here. Have we answered the question? I would say no. This is really just the beginning. What we've learned from the direct left atrial implant trials is that there may be a difference here between the phenotypes of HFrEF and HFpEF. And then the other thing is that the placebo effect was major. There was a 10-point KCCQ improvement, even in those patients that just got a sham intervention, meaning they just had this 18 French stuck in their neck and they felt better after that. So that's something that's really kind of important to keep in mind here. That may not be the perfect endpoint for these controlled trials. And so we have a lot of work to do in defining what phenotype would benefit. And finally, the mode of shunt may be important. Perhaps the direct interatrial implant is not the way to go. How about direct transseptal puncture? And this is the Corin catheters. And the early experience with the RF ablation catheters is basically long-term shunt patency. It's hard to control how big these holes are, and over time, lots of pannus and inflammation, and they've had issues with that. The Corin catheters show more promise, and there's some early feasibility trials going on right now, but the same concerns exist. You're introducing a direct connection between the left atrium and the right atrium. We always worry about embolism, infection, et cetera, and then long-term patency of these direct shunts. So I want to talk a little bit about the Apture system, which is the novel shunting approach. This is the only device of its kind where the implant is done through a left atrial and coronary sinus connection. So the operator would place a right IJ sheath and enter through the coronary sinus in the right atrium retrograde and puncture a hole to the left atrium and place this 7-millimeter diameter shunt device here. So obviously the benefits we think are to preserve that interatrial septum. And why is that important? There's a lot of really interesting MRI data coming out about RA flow dynamics. And once you interrupt that septum, you're creating kind of this RA diastology and these problems with flow through the right atrium. So it makes sense to kind of keep that septum intact. So what's been done so far is the AltFlow-1 study. This was the early feasibility study, and we were a site for this, and 87 patients were randomized into this. And I'm sorry, it wasn't a randomized control trial. It was just you get the procedure. And rigorous, you know, the nice thing is we did very rigorous hemodynamic studies to actually prove that there is an issue with exercise and that we would see the wedge go up. What we saw by and large was an improvement in KCCQ, and I just gave you the pitfalls of that. But for what it's worth, people felt better. And importantly, there was a reduction in the exercise wedge pressure compared to baseline by about 7 millimeters of mercury, which is big when it comes to symptoms. So back to our patient, this is his baseline, and this is our setup. You saw a picture of this earlier this morning. This is our bike. We have the watts on the screen. We stick this under the cath lab and patients can pedal. At baseline, again, pretty normal looking numbers. If you stopped here, you would not have made the diagnosis. So at peak exercise, what we saw is a dramatic rise in PA pressures and a dramatic rise in wedge with a concomitant V wave, suggesting that this is really the hallmark HFpEF. This is the classic diagnostic strategy here with exercise, normal at rest. He underwent the implant of the Apture device from the coronary sinus to the left atrium. And this is a short axis view focusing on you can see this on short axis, looking at the shunt. And this is just showing you that the direction of the flow is really from left atrium to coronary sinus. And there's very little flow the opposite way, and all just really from pressure gradients. And it's visible on echocardiogram. And at 3-month follow-up, we repeated the exercise bike test. And what we saw was pretty commensurate with the results of the ALTFLOW 1 trial, is that the wedge at peak exercise suddenly did not go up to the level as prior. And we didn't see a V wave, which is really interesting and really kind of a something to think about, that the V wave completely disappeared with exercise. Although the wedge went up, there was no evidence of diastology by the hemodynamic tracing. So this is kind of a nice initial experience to prompt us to do further research into this. So again, unanswered questions. What's the ideal phenotype? And should we be looking for exercise pulmonary vascular disease? Is there something else we can use to figure out who would benefit from this? And then obviously the trial design, we should have a sham control. And then what are the long-term effects of this? You're creating a small hole from the left atrium to the coronary sinus. What will be the long-term effects on the right ventricle? So we need more randomized control data to answer these questions. And that's where the ALTFLOW 2 trial comes in, using the same Apter transcatheter system. We've just been activated, and we plan to enroll 100 patients, 50 in each arm. These are just basic inclusion-exclusion criteria, but this is a HEF-PEF or HEF mid-range EF trial, and includes a sham arm. And what we're looking for is a combined endpoint at 30 days and a change in exercise wedge. And with that, I'm going to end. Thank you very much. We'll take any questions that you guys might have. Go ahead, Marcelo.
I'm going to pose a question from like a layperson kind of point of view. Because this type of shunting causing increase in the pressures of the blood entering the right atrium.
Yeah, and that's a really great point. And this is why I bring up what is the optimal shunt size, what is the long-term effects of this. I have to say, in our initial experience with the ALTFLOW 1, there was no change in RV cardiac output, meaning the QPQS, and these are all things that we measured pre and post in the cath lab, looking at how much flow is coming into the right side. And at least our initial experience in our limited time follow-up, we don't have any suggestion. And interestingly, in the V-Wave trial, they did look at exercise or echo parameters at 1 year in these patients that had a direct interatrial puncture, and actually the RV function improved in a subpopulation of patients. So a little bit unclear. There's a lot we can learn about this, but so far there's been no signal that this over time will lead to higher RV flows. But this is why it's really important in choosing the right mode of shunt, and is also the right diameter and how large of the shunt is. So a lot of data, preclinical data went into this.
And there's actually more data coming out. My understanding from the intraatrial shunts is that the right ventricle is adversely affected. It's just less so with the shunt, but it's adversely affected in all intraatrial. The ALTFLOW 1 study, this was only collected in Absalom with the papers coming out. It's the only study with this new shunt where there over time MRI studies no adverse effect, no increase of vitamin D effect. It's the only shunt, to my knowledge, where that has been shown in this monthly public.
Right.
Thanks.
Thanks. Oh, one question. Yeah.
One question. Is there any risk of stroke with this procedure?
Yeah, so the question is about risk of stroke with this procedure. We have not seen that risk, and that was kind of our rationale as to why we didn't opt for participating in any of the interatrial shunt trials, because you're creating this kind of direct, and certainly with the initial experience with the interatrial shunts, there was, in the Corvia trial, a trend, a signal towards more cerebral vascular events. So for that reason, we opted for this kind of novel approach with left atrial to coronary sinus to shunt, but we have not seen that.
We do the ablation now in uninterrupted ablation. So of course, anti-coagulation goes because we have atrium, but we don't stop it. We have proven better embolic events with uninterrupted. So probably the patient just should be on oral anticoagulation uninterrupted for the patient to time to prevent multiple problems.
Okay, terrific. Thanks, Sandhya. So this one technology that we're doing here, so if you have a patient, send them to us. Another technology I'm going to briefly show, the outflow study, I am on the steering committee for the new study, and this one actually is a global study already that we're also leading. Well, let me get the camera on. Great, so I'm going to briefly show you a different technology. Oh, camera, wait, oops. You do it. Oh, let me move the whole thing.
You should have more time.
Here I am. Okay, great. Briefly show you a new technology that we use in HFrEF. And I'm going to skip the background. I just want you to focus on the right side of the slide here. This is COAP, this is TIER, and this slide shows you the increase in left ventricular size or remodeling over time with or without a mitral clip. And in heart failure, it is well known that the enlargement over time is bad, remodeling is bad. And what this study shows in a therapy that is well established to improve mortality, mitral clip, even in the clip group, there's further remodeling. What we believe is that an active approach to making the heart smaller and induce biological reverse remodeling after might be helpful. This is the AccuCinch device, which we have used at Montefiore a few times. Essentially, the operator goes through the aorta, femoral to aorta, into the left ventricle, places a navigation catheter, then places a set of anchors and sliders into the ventricle with a line through it, and then just cinches and makes the ventricle smaller, approximately 2 centimeters below the level of the mitral valve. And you see this here again in the cartoon. This is how this is placed, and then it is made smaller, and then it is cinched acutely to reduce the LV size. These are pictures from our lab. Anchors and sliders have been placed, and if you watch the movie for a few cycles, you will see that they are pulled together, and they're being pulled together right now to be made smaller after placement. In the end, they were moved basically from the position in purple here to the smaller line, and the ventricle at that level is made smaller about 1 centimeter, 9 to 10 millimeters, which is about 14 to 16 anchors that are usually used. What happens over time, this is one case here, an anecdote. In pink, I guess, is a reconstruction of a CAT scan with a large heart, CT contrast remodeling. And in blue, you can see this is smaller now over time, but it's not just smaller up here where we actively cinched, but the entire ventricle has gotten smaller. This is what this implant looks like when you put it into the sheep and then sacrifice the sheep. You can see it right here, the anchors and the sliders. This is 10 days later in a living person where the implant is beginning to significantly endothelialize. This is a patient that 3 months after the implant had heart transplant, heart was taken out, and you can see that the implant is now completely integrated, and you have kind of a tissue or scar girdle at that level. And here's a cut through that cinch line, and you can see in white is the cinch line or a suture really, and the tissue has infiltrated. So full integration of this device, if you will. I'm going to show you a convenient sample of 51 patients from 4 different studies. Only patients that did not have severe MR, had to have MR less than 2, and had an ejection fraction of 20 to 40% after GDMP were included in the study. This was kind of a standard heart failure population, slightly younger though, 75% non-ischemic, ejection fraction 29%, and the left ventricular end-diastolic 200, that's quite large. These patients were fitted with this device in an open label situation. Safety at 12 months is shown here, pre-specified adverse event. One patient had a procedure-related pericardial tamponade, was drained, the patient did fine. 3 patients, this is a 20 French access sheath, this is big in arterial sheath. 3 patients of these 51 had arterial complications that all resolved without sequelae. And 1 patient had a stroke 1 week after the procedure. This patient was in atrial fibrillation, anticoagulation had been held. Fortunately, this also resolved without sequelae. So a fairly good safety profile. And for the vascular accesses had to do with the perclose technique. We've now done over 80 patients in a different study without a vascular event. And here's what we saw. In KCCQ improvement, you heard earlier from Dr. Yancey that 3 is something, 12 is huge. This is about 20 in KCCQ, but you have to be very careful. If you have a medication placebo-controlled trial and the patient doesn't know what they're taking, and then the KCCQ improves, that's meaningful. Sandhya just showed us in the Relief HF, you had half the patients getting a device placed and the other half just had a big catheter put in their neck and they all felt better. And they felt better by 10 points. So you have to be careful with this. 20 is a lot, but the patient knows they have the device. The person that put it in tells them every day how great they look. So take it with a grain of salt. Similarly with a 6-minute walk, but a 50-meter improvement is quite a lot. Patients did much better. Now, in contrast, echo data here show, or not in contrast, in line with this, but a little bit in contrast in terms of the patient knowing what's going on, or the observer. This is data on left ventricular remodeling, how the ventricle gets smaller. And you can see over 12 months after putting in the device, there's an initial shrinking of the heart, if you will, because you make it physically smaller. But after that, nothing else happens to the device. And then there will be, or there is, biological reverse remodeling. And of note, this echo data is blinded. The reader does not know when the echo was done. Is it baseline? Is it later? The reader can sometimes see the device, but of course, everybody has the device, so it doesn't really matter. So this was very intriguing data that we published also in the Journal of Cardiac Failure recently. This is just to illustrate this again, the initial physical remodeling, and then something is happening to the heart. The idea is that you reduce the wall stress and you induce biological reverse remodeling. This seems to be happening. This study is ongoing. I co-chair this globally with interventional cardiologists. We are in step 1 trying to reach 250 patients. We now have 155 patients either randomized or approved to be randomized, and we hope to reach it to 50 point in October. Who should be considered for the study? We have actually consented 16 patients here at MonteHeart. Ischemic or non-ischemic EF 20 to 40%. Their left ventricular end-diastolic diameter has to be at least 55, so you can make something smaller. They can't have significant MR. They have to be on optimal GDMT. If they have an ICD indication, they have to have an ICD, and they have to have a certain 6-minute walk to qualify for this. Here's where we are right now. Actually, we had a meeting at New York Valves 2 days ago, and some of the international sites are just coming on. And our team has done a really great job randomizing into the study. Let you read the slide yourselves. But those two studies, the outflow study and this study, are studies, investigational studies we offer to patients with HFpEF. The former, and with HFrEF would be this study. Thank you. I can take questions. Otherwise, it's just a technology. We can move on. Maybe the surgeons, do you have any comment on this? Since you have failed to do this with Stitch and Batista and everything else. Shivank.
Thank you for the talk. So what about the, have you seen data regarding left atrium remodulation? That left atrium remodels. Most of these patients have like increased LV pressures. They'll have LA enlargement.
You know, that's a great question. I'm gonna, yeah, I don't think we have looked at that or plan to look at that. So there's your stop study. Thank you. That's great. It's a great question. Let's move on. I can see who's next.
And they were talking about now the investigation is now a reality. How do you get here?
Exactly. Yeah, that's a really good question too, which we'll talk about later. So if you're staying for the cases, there'll be great discussion about that. So I was asked to talk a little bit about tricuspid therapies. That's kind of been the new hot topic since now we have some approved devices. So before we start, these are my disclosures. Edwards is the company that makes the Evoke valve. So there's an institutional consulting contract on my behalf here. And then this is just the quick outline. So just to make sure everyone's on the same page, we'll just talk a little bit about the background and prognostic implications of untreated TR, where transcatheter therapies for this came from, and then how we got to now 2 approved devices in the United States. What are these sort of alternatives, and then what are still these unmet needs and future directions for the field? So if we think about the clinical burden of TR, it's no surprise, just like all the other valves and valve disease, we do see an increasing prevalence when people are a little bit older. Importantly, this can happen either in isolation, but very commonly as secondary to left-sided heart disease. But regardless, the incidence rates are still climbing in this type of pattern. And we do know that regardless of the method that you use to actually try to define severity, the more severe it is, the worse your outcomes are. And I don't have all the graphs here, but that's again, either an isolated TR or in the context of other types of heart disease, especially left-sided heart disease. The surgical context, and I have a number of surgeons in the room, happy to get their comments later about this as well, is that the surgical trends in terms of numbers of isolated tricuspid procedures really hasn't changed that much. This is a little bit older data from 2003 to 2014 from STS, and we don't see a huge sort of increase in the number of procedures. And then there's some newer data that came out actually last year, just looking at kind of the 20 teens, I guess. And again, we're seeing a slight increase in the numbers, but not really in a dramatic fashion. And why is that? I mean, we always were told in the past that isolated tricuspid surgeries carry a huge risk of mortality. Sometimes the numbers that get thrown out there are exceptionally high. You know, again, we have slightly newer data that maybe tells us that that was a little bit of an overestimate. So it's not like, 20% or something really horrible. Coming from STS, it looks like at least in a slightly more contemporary cohort, it's sitting around 7% in terms of operative mortality. And then these are some of the other sort of risks associated with surgery. And then certainly there's patient selection sort of factors here that I'm sure modify those risks. And again, be happy to get some comments from the surgeons afterwards. So we don't have great calculators to figure out surgical risk in a lot of these patients. STS doesn't have one for isolated tricuspid procedures. There is this one that came out of Europe and in France, so it's being used in a lot of tricuspid trials now called the TRI-score. So it's a composite score that takes a number of different factors, and then based on that, attempts to at least estimate the risk of an open surgical procedure for the tricuspid. So that's sort of the best that we have right now and is what we're using most of the time. So because, again, this was a little bit of an undertreated condition that everyone was really afraid of the surgical outcomes, it really did lead to this explosion of transcatheter options and investigational devices. And they targeted all sorts of different things: leaflets, valve replacement at the valve, so heterotopic, and orthotopic, so valves that are not on the valve, as well as annuloplasty type devices. And then the one we'll focus on today, of course, is the Evoke replacement. And then so we think about sort of when this started, actually not that long ago. So in the pipeline of when, devices start investigationally and get approved, usually it actually takes a very long time. But, the first reports of using really off-label MitraClip to clip the tricuspid was only back in 2016. So it's actually a very young field if you think about it. And then replacement also started around the same time. So this was the first replacement device. It was called the Navigate. Pretty bulky and a little bit clunky, bad delivery system. But at the end of the day, it was a little bit of proof of concept in the field that you could actually introduce a valve replacement through a transcatheter technique. The data that we had up until more recently with some of these device pivotal trials was all observational. So this is a propensity match study that came from the TriValve registry, which was a basically multinational, multi-site observational registry on people undergoing transcatheter tricuspid treatments. So my prior hospital in Toronto and Azim's prior hospital in Italy were part of this registry. And at least in an observational fashion, there was some signal that maybe these patients do benefit from treating their TR. But of course, it's always subject to the biases of observational data, especially when it comes to procedures. So then I'll introduce a little bit about the Evoke device and then talk about some of the data behind it and what we know and what we don't know. So this is the Evoke valve. So it's a double frame design. So there's an outer frame that essentially will touch the native annulus. And I'll show a quick video of that so you'll sort of see what that means. And then there's a smaller valve inside. And that's just because most of the time we don't want an enormous valve. The tricuspid annulus is quite large. So this valve comes right now commercially in 3 sizes, 44, 48, and 52 millimeters. And as you can imagine, you don't really want a 5-centimeter prosthetic valve. And then it also doesn't give you sort of future options of valve-in-valve, for example. It's in a relatively bulky delivery system, so 28 French. And then it's a very cleverly designed system that allows us to actually steer very precisely. And then the idea behind this double frame, again, is that it conforms to the native annulus, so it will provide good sealing, but will still give you a relatively circular valve in the middle, just because the 2 frames will move independently from each other. And then you see, if we're looking from above the valve, there are these balls that kind of circular all around the valve. And what those are the actual anchoring arms that hold the native leaflets, and that's how this valve actually stays in place. Kind of annoyingly, there are 9 of them. I'm not sure why it's not an even number. It makes at least imaging of this very challenging. So what happens with this procedure is it's a transfemoral approach. We put a wire first in the right ventricle so that we have some sort of rail to follow over. We'll place the catheter in place in the tricuspid annulus. We use different types of flexion to centralize. We open those arms. We grasp the leaflets inside like a basket. And then when we're happy with how everything looks, then we actually move on to full deployment. And initially, these procedures took quite a bit of time, an hour or 2 hours. Nowadays, many centers who have a lot of experience, if the patient has good imaging, this type of procedure can actually be done in about 30 minutes. So we actually know that this has, come a long way. There have been several hundred implanted in the clinical trials, and now it's in sort of commercial status, of course. So if we think about sort of the data behind the EVOQUE, so the first in human was done actually at my old hospital right before I came to MonteHeart. So in May of 2019, this was in a patient who our surgeons thought at that point was too high risk to undergo cardiac surgery. The gaps were too large for a tricuspid edge-to-edge repair. So we offered this as an option. He's still doing very well 5 years out, a good valve function, good clinical status, and significant improvement. From there, after there was an initial sort of compassionate use cohort, they moved on to an early feasibility study, which was called the TRISCEND-1 study. MonteHeart was a part of this, and we enrolled a number of patients. And what we knew from that non-randomized trial, obviously not blinded either, is that TR severity is significantly reduced, no surprise, and NYHA class improves. With that said, there's obviously caveats to NYHA evaluation, especially if you know somebody's had a treatment or not. KCCQ improvement was quite significant. Again, not blinded, but more than 25 points. So that seems pretty significant. But importantly, there were some risks that were identified, including procedural-related mortality and heart failure hospitalizations were still quite high. From there, they moved on to the TRISCEND-2 study, which was a pivotal study. It was a randomized controlled trial, 2-to-1 device versus just medical therapy, which is basically just diuretics. And then if we look at least the analysis of the number of patients who had some degree of follow-up, so this is not the entire cohort, but this is the only information we have from the trial so far. That's public knowledge. We do know that these patients started with approximately the same severity of TR, that's on the left. And on the right, no surprise, when you put in a valve, obviously the TR goes away versus if you treat them medically. Surprisingly, if you look at that medical side, which is the bar at the very right, there is actually still improvement. And maybe that's also the effect of being enrolled in a clinical trial, because obviously the follow-up is a lot better. Potentially people are being pushed a little bit harder on the diuretics. So there's still some benefit to medical therapy for sure. And then if we look at the KCCQ change, so again, looks like a pretty decent number, but as Sandhya pointed out, there's obviously a lot of placebo effect that goes into this. So there are some caveats to sort of this information that we're seeing. And the NYHA, same thing. I think NYHA probably is a little more subjective. So I sometimes don't believe NYHA data, but, for whatever it's worth, patients report at least feeling better. And then lastly, the FDA approval packet that the company sent in gives us yet another snapshot of what we know about benefits and risks. And this is sort of what they're reporting at 6 months with, again, a limited number of patients, but it does still look like there's very significant TR reduction. Again, no surprise when you're putting in a valve, but at least we know that these valves don't seem to be failing at a very early point. So it was commercially approved in early February. We did our first commercial case at Monte not that long ago, actually. An 83-year-old who would have been a redo, very symptomatic from her severe TR. It was a pretty quick procedure. She went from massive TR to trace, and she's doing well at 30 days, and hopefully will continue to do well. And then if we then just kind of nail down on some of these FDA submission papers and the risks and benefits. So again, if we're looking at just TR reduction as a whole, out to 6 months, it looks like there's good sustained TR reduction. Usually when we see some residual TR, there's just a little bit of intravalvular TR that's left because of the crimping time of the valve. We're not seeing huge amounts of PVL or anything like that. And at the end of the day, if you have trace or mild, probably clinically, there's no real difference. This is NYHA data. So again, significant improvement, but how much is placebo effect? We always have to account for that. These are the KCCQ numbers. So again, improvement, as we sort of mentioned. And then this one's kind of an interesting curve that we'd like to follow over time. This was all-cause mortality. And what you see here is that, the two curves are very close together. And the question is just at 18 months, is it starting to split apart? Again, we don't know. There's some discussion that, this is maybe why this device was approved without an FDA panel versus edge-to-edge required a panel discussion, because maybe there was some, again, signal here. But this is not the entire cohort again. So, time will tell. But this is sort of interesting for us to at least think about. There are important risks to identify and to recognize in tricuspid valve replacement. So at the end of the day, it's not a risk-free procedure by any means. So there was some mortality associated with the procedure. And then the real Achilles heel with these types of procedures is bleeding problems, which I think our surgical colleagues see as well in surgical tricuspid procedures. And then pacemaker rate is quite high. So in this particular subset of patients is about 15%. So that's very significant for us to sort of recognize. And then if we just think about, what are the alternatives? So obviously there's medical therapy, but we also have another approved tricuspid device now, which is the TriClip, which is edge-to-edge repair. And that's mechanistically different because what we're doing is we're pinching the edges of the leaflets together to improve coaptation. What we know from the Triluminate randomized control trial is that the amount of TR reduction you get is not as good as replacing the valve, which is maybe not too surprising, given how large some of these valves and gaps are. So you do still have a significant number of people who end up with moderate or severe residual TR. And some of the symptom improvement seems to be correlated with how much TR you're left with. What's pretty reassuring about this is that this procedure does look like it's quite a bit safer. So the bleeding risk, the pacemaker risk, mortality risk is much lower. So it's always this little trade-off if we are thinking about intervention for a patient, how much efficacy do we want versus a little bit higher risk associated with that. There's still lots of other investigational options because at the end of the day, these devices, unfortunately, don't fit everyone's anatomy. So there's still leaflet approximation devices under investigation. The TriClip's approved. That's why I X'd it out. Annuloplasty devices like Cardioband that are coming back into clinical trials pretty soon in the United States. And then valve replacement, that gate device was very bulky, not a very good one. So it's actually gone. But there's a number of other replacements that are still in investigational status right now. So future directions and the ongoing unknowns. So what we really want to know is what's going to happen to these heart outcomes. So heart failure events, cardiovascular mortality, is there really a signal towards some benefit or is it really neutral? Probably mortality will be the easier one to really look at. The heart failure events, and obviously I'm in a room of heart failure experts, so it'd be interesting to get everyone's input there. It's a challenging population to study because you have some TR patients that really have very refractory and recurrent heart failure admissions, but they're also very late stage when we look at the status of their RV and how wide apart their valve really is. Versus the ones who are just at the severe or even massive tricuspid regurgitation, they tend to be symptomatic and usually more from the low cardiac output because of forward flow limitations, as opposed to the congestive symptoms and recurrent admissions. So it's like, how do you find the sweet spot to study that? I'm not really sure. So that's a definite ongoing unknown. And then, so that also then brings up the question in the future, how early should we treat? When are symptoms considered significant and prognostically significant? And when is it actually too futile and too late? And then the other important priorities, of course, we want improved bleeding risk. So lower profile delivery systems, There is a signal for valve thrombosis in some of these devices. So we want to, of course, have a reduced risk of that. And then pacemakers, as I mentioned, we'd like to see that as close to zero as possible, of course. From my point of view as an imager, I'd love if the tricuspid was easier to image, but unfortunately it's not. And then if we could do shorter procedures, maybe even with ice, maybe they can be done with conscious sedation like TAVR is nowadays. So in summary, hopefully this was a little bit of a review just in terms of the TTVI, so interventions in general landscape and how things have changed, and they've now actually gone into the commercial realm. So Evoke is now FDA approved. So it's something that we can potentially offer for, again, all we know is symptom benefit right now. And there's good clinical experience out to about 5 years so far. I do know that we'll continue to get more and more data as the years progress, and then that will inform us a lot better on how we pick these patients. Thank you.
Question from all the any point I think the criteria was very different in CP 22 and the version 50, and CP 22 version 20. Number two, what are your thoughts about the FDA approval device? It's very controversial reason because there's no heart potential to suggest. I think that's actually the first.
Yeah.
No heart potential in this no survival benefit at all. I think, and the issue of the pacemaker, that's higher than the surgical rate of the pacemaker than else. So we can honestly thank you.
Yeah, no, they're great questions. I'll answer the question about the FDA piece first. I mean, I'm not the FDA and I wasn't on the panel discussion, so I'm not really sure. But I do think that, a lot of these tricuspid trials in particular, and a lot of the valve trials, maybe this is a little bit of a, trial nuance thing, but a lot of them have sort of switched to win ratio kind of models to try to hierarchical, organize some of these composite endpoints. And so if you look at the way Triluminate was kind of reported and how they actually did put in the FDA submission packet for Evoke as well, if you use one of these kind of win ratio models, then it technically is a win on the device side. So, exactly. I mean, it depends on how you want to make the argument. I completely agree with you. We clearly don't have a signal for the hard outcomes, but there's, in theory, some benefit. And so I think that that's sort of what drove that decision-making, but I obviously can't speak for the FDA. I agree with you about the pacemaker rate being quite concerning. That's something that plagues tricuspid valve replacements for transcatheter. And it's something that we're actually trying to figure out. What are those predictors? How can we be better at understanding who's at really high risk of that or not? We're actually just starting a new registry with a number of different other sites around actually the world to try to actually figure out some of those risk factors. And hopefully that will help improve outcomes in the future. And then your other question was about the hemodynamics, right? And that's about patient selection in terms of their outcomes. Yeah, it's a good question. And I think I'm going to get Sandia to try to answer that one. I think, at least from an imaging point of view, it's very hard to understand RV function in the context of torrential TR. And even RV function in general. Honestly, we're not very good at it. And so how do you predict when it's, the dysfunction is too significant that they're going to go into RV failure and have afterload mismatch? Again, we don't really know. There's some concepts being thrown out there like RVPA coupling. So, is it coupled? Is it uncoupled? The RV function in context of afterload, but all of that is still under investigation.
Before you do something, if the patient with a wide pore power, you're close to the aorta is close to the even the surgeon, if you touch the block by answer. But here, why you think that the size is too big that you basically stretch the conduction system, or what's the issue? And how safe is put wires or even leadless through these things one?
Yeah, no, great questions. So I think the reason for the pacemaker risk in these situations is about the radial force of the valve. If you look on the echo, once someone has an Evoke in, it's really pretty bulky at the base of the RV. So it's clearly pushing the septum and it's pushing the free wall, and that kind of compression factor for sure. A lot of these companies that are trying to develop new valves, they're trying to decide how much radial force is enough for stability, but not so much that you're going to cause all these pacemakers. So that's a little bit of a question that hopefully we'll be able to answer. In terms of the post pacemakers, so the ones that we've had here, most of them have been managed with a coronary sinus lead. We have had one that had a leadless, I mean, you probably know better than me in terms of the safety of implanting them. But I mean, they all went well. So
No, it's just, going through a new valve, going across it makes up emergency.
yeah, fair enough. Yeah, we tried to do ice guidance for the leadless, but it was pretty challenging to see actually.
Can I ask questions? Many of these patients with severe tricuspid regurgitation, they have pulmonary hypertension, and there is a level beyond which you will actually cause harm. And some people have used like medical treatment of pulmonary hypertension, and then I think up to the limit of three units, they are doing the procedure. My question is, are you maintaining these people on the pulmonary hypertension regime? And second question, does after valve has been put in, is the pulmonary hypertension going down? And do you see patients where right ventricle actually worsens because this is actually end stage of right ventricle dysfunction?
Okay, this is a great kind of segue to the hemodynamic part of this,
Yeah.
because, the nice thing about all these trials is they mandated, most would mandate right heart caths prior to implant. And there was a pretty rigorous exclusion process for anyone that had a mean PA of over 35 or a wedge of over 25. So we made it a point to look for patients with low PVRs at baseline, as well as no significant fixed intrinsic PAH. What was really interesting about all of these hemodynamic catheterizations is that a majority of the patients did not have elevated right atrial pressures. And this kind of speaks to the compliance of the right atrium. So the shortness of breath thing was always a little bit confounding, because why would they be so short of breath with normal right atrial pressures, or right atrial pressures that weren't significantly elevated, maybe 10? So I think the key here lies in that we see all these hemodynamics at rest that look pretty good. Not everybody has a low index, but the exercise hemodynamics, I think, is really where the money is, as far as kind of distinguishing the phenotype that may really benefit from this, and maybe explain why some people don't get better. Maybe they have exercise pulmonary vascular issues, or, we don't really understand this so quite well, but that kind of wraps it up as far as the hemodynamic part of this, is that there's a lot to learn from not just the rest, but the exercise hemodynamics, which I think we need to be doing routinely.
No, I agree with all of them. I just want to give it a spin on all of this from the tri-cliff experience, from the repair experience. A couple of methods. One, heart failure admissions. If you have mitral regurgitation that's severe and you get heart failure, you're short of breath, the doctor's going to put you in the hospital. If you have tricuspid regurgitation and your legs start to swell, even that, the doctor's not going to admit you. So that's a big lesson in terms of capturing the event rates to reach a goal. The other thing that this is almost a rescue therapy. When the RA pressure is 22, 25. And when you look at the triluminate study that was in New England, the mean atrial pressure was only 10. And I was very involved with this, and I'm beginning, why are we studying the patients? But as Sandhya said, put these patients on an exercise regimen, and it's going to go up to 20.
Right.
So what they are exposed to during their daily activities has nothing to do with what you see when they're on the catheter table just lying around. And from the TriClip study, some data is coming out that the European Society this year, probably we will treat these patients earlier, and probably there is more benefit based on the beginning of the decline in renal and hepatic function. You're not going to see a patient with VLO4 anymore like now.
Yeah.
But in the future, I believe exercise testing and the hepatorenal situation will dictate, and we will begin to understand when to intervene. And most of the time, probably we can still put the tip because they're not as advanced.
Agreed, fully agree.
That was outstanding. Edwin, thank you. Edwin
course.
was giving, I don't know, 8 talks with the New York Times really. So thank you for coming up. Thank you for coming down. Okay, so we'll close out the device section with the ultimate device from now. Danny Goldstein is professor and vice chair of cardiac surgery, and most importantly, my co-conspirator for the past 10 years and the board director of this meeting. And one of the leading vasculitis in the world, one of the 4 share some of the momentum trial that put the heart rate on the map. So then he's going to give us an update on, I guess it's on heart rate 3, but it says global outlets.
Thank you, Uli. And I always start this talk by thanking you for being the source of brainchild for this meeting. I want to thank also Stacy and Millie behind the curtains who made it all happen. If you look at that handout with the schedule, has me and Nazim as co-directors. I think we just co-ornaments. This is really the work of Uli, and we just sort of ride out his coattails. So these are my disclosures. I also want to say that I will not discuss unapproved devices, but I'm going to shamelessly promote MonteHeart's impact on the field. So if you ask me to characterize the LVAD field for the last 4 years in one word, I would say boring. And why do I say that? In 2018, there was a change in the allocation system, how we give hearts out. And that sort of completely decimated the field, not completely, but tremendously decimated this field of LVAD, because it favored people with short-term devices to get a heart, and it disfavored people who had an LVAD. So it became what we call status 4 in the list, and those people were not getting transplanted. Along with that loss in clinical activity, there's a lot of loss in academic activity. And for us who went to the ICLT meeting every year, we'd see less and less abstracts and less interesting abstracts when they made it to the program. So I then looked at, in preparation for this talk, to see what's happening in the transplant world now, and how can I put an exciting talk together. So if you think of what's happening in transplant, number one, there's been a political upheaval. UNOS, as you all know, is the nonprofit organization that's basically contracted by the government to run transplant, solid organ transplant in the United States. And it's in the midst of an overhaul. Why? Poor accountability, technology just in the 1990s, and just poor oversight. So now there's a bid for someone to supplant the UNO. So that's a big deal. The OPOs are a disaster. There's 54 OPOs in this country, 65% underperform in terms of number of organs acquired, numbers of organs transplanted. DCD donation after circulatory death. This is a new sort of ideology and any new approach of acquiring organs, and it's a wild west. What do I mean by that? This process requires the patient not to be brain dead, but to be terminally ill because of his brain. And we basically extubate the patient and allow him to die, and then we recover the organs. The problem is we cannot predict death. We're not good at it. There's no science behind it. There's a huge variability in how much each hospital, each state, and each country allows to wait until the patient dies, and how much you can wait standoff, what we call, okay, the patient's dead, nobody can touch your patient for 5 minutes. In Italy, you have to wait 20 minutes. So, and that's obviously has important implications on ischemic times and what happens to the heart. Dry runs. What I mean by dry runs, the technology has become very complicated in getting hearts, and there's very costly devices, and we're renting teams out to go ahead. And if we don't recover a heart, there's tens of thousands of dollars that go down the bucket. So the cost of transfer increasing, the profit to hospital decreasing. So these are all issues that are happening in transfer. What else? Ethics of NRP. NRP is normothermic regional perfusion. That means the patient, take the brain tube out, they die, you wait for 5 minutes, then you put them on ECMO. So you're restoring the circulation after the patient's been declared dead. A lot of people are uncomfortable with that. A lot of institutions are uncomfortable. Colombia, down the road, will not do NRP DCD, for example. There's been a transformational change in transplantation due to the availability of machine perfusion technologies, transmedics, Paragonics, et cetera. I would say it's almost as impactful as the advent of cyclosporin. So again, a lot of other stuff, a lot of excitement on the field. There's this general dislike with the allocation system for the reasons I mentioned. It helps in geographical parity. It hasn't helped a lot of LVAD patients, sensitized patients, et cetera. There's this, and Snehal is going to talk about this tomorrow. There's xenotransplant now. 2 patients in the world in the United States have gotten a pig heart. And I'm sure he'll talk about the outcomes on that. The public is watching this. Last year, this famous writer spoke about her 2 transplants she got. And she said, I'm dying. She was dying from metastatic breast cancer. 2 weeks after she wrote this article, she died. And it's a very compelling and controversial article. And then just a couple of weeks ago, this came out. So clearly there's a lot of excitement on the field that we don't have an LVAD right now. And there's this. Is there a volume?
Friday with my daughter.
So anyway, so it's just around the corner before we start transporting hearts. By the way, anybody wonders, there's a parachute in that system. So if the system fails, GPS fails, parachute will deploy so you don't lose the organs. So in the setting of this, I got to try to make this talk exciting. And there's some data that's come out in the last year, and I think I'll do a reasonable job. There's data on long-term survival, and I'll share with you Momentum, 5-year data, Intermax data, and Elevate data. This just came out recently, the ARIES trial, abandoning aspirin for people who are getting HeartMate 3 devices. There's a whole concept of recovering the left ventricle is acquiring momentum, so to speak, in the field. And there's some pipeline devices that seem to be exciting. So let's talk about long-term survival. When you talk about cancer, long-term means 5 years. When you talk about cardiovascular outcomes in most clinical trials, it's 5 years. We in the MCS field have been married to this year, the idea that long-term means 2 years, and that's sort of bullshit, right? And really we needed 5-year data to convince ourselves and our patients and our cardiologists that this is really meaningful therapy for the patient. So I remind you of the 2-year data. This is a Momentum 3 trial, 3 New England Journal articles, and basically the result of the engineering brain behind this device, right? The HeartMate 3 device, which most of you have seen, which I show the patient when I talk to them. This device was specifically designed not to improve survival, but to improve hemocompatibility-related adverse events, i.e. bleeding and thrombosis. And it was done by increasing the size of the spaces where the blood flows. It was magnetically levitated, so there's almost no friction. And there's an intermittent washing of the device, so you get no stasis, clots, thrombus, which is the big problem with the prior device. You add those 3 things to the experience we had in managing people with a HeartMate 2 device, and boom, we have the HeartMate 3 results. And this is the full report, and here's the sort of the money slide, a 15% absolute improvement in the primary endpoint, which I remind you is survival free from a disabling stroke or a need to replace the pump. Monumental, HeartMate 2 went into the garbage, and HeartMate 3 became the device. And if you look at survival over 2 years, this is the medical management of the rematch trial, the famous trial that compared optimal medical therapy versus the HeartMate XVE device. The XVE device won that battle. However, most people died. They got the XVE because the device was too unreliable. People got infected, incredibly noisy. Then came HeartMate 2, the DT trial. Then came the HVAD BTT trial, the HeartMate 2 LVAD trial in 2017, HeartMate 2 LVAD, same device, better experience, HeartMate 3, Momentum, and look where transplant lies. So we now acquired 2-year survivals that are comparable to transplantation. That's pretty damn good. But what happens beyond that? And clearly, this is prove that technology beats patient management. You got a better device, people do better. So what about 5-year outcomes? Well, here's the 5-year paper that came out in JAMA, and it showed the composite, the endpoint's the same, right? Survival field of important stroke or pump thrombus, or need to change the pump. You see an absolute 24 different percentage points difference in the endpoint. And if you look at overall survival, well, look at now. We have 58% survival at 5 years with the device compared to 44 with the HeartMate 2. Pretty damn good. And if you look at the adverse events, remember, this device was designed for that, not for the survival. And you can see all bleeding and all strokes, the point estimates favor HeartMate 3. So that's great. So that was Momentum trial. But you always question, well, what happens when the device gets approved and goes to the real world? Are we going to mimic the results of the trial? And now we have the experience in the US based on the Intermax database, which, as you know, is the biggest Registry United States about durable devices. And my two colleagues, Uli and Omar, headlined this very important paper, which is the annual report of the Intermax trial. And then the curve on your graph on your left, you see the increased use of HeartMate 3. That's the green bars, the reduced use of HeartMate 2 and HVAD, and the red bars. And the numbers don't seem too big in the 2000s. That's because people who were in the Momentum trial were not included in Intermax. So the numbers are more closer to 3,500, 4,000. The sobering thing is, if you look on the right, we're not helping more people. We're helping people differently. So yes, there are more transplants because of that allocation change in 2018, but we're doing less LVADs. And basically, we're helping 6,000 people when we think there's between 50 and 100,000 people in the United States that could benefit from a left ventricular replacement therapy. And there, in this very same paper, who's getting these devices? Well, 72% are Intermax 2 or 3. What do you mean? They're on a machine or they're on inotropes. Another 10% are Intermax 1, so they're dying. So altogether, 82% of these people are the ones who are getting these devices. The cardiologists and the patients are not sending people who are relatively healthy for an LVAD therapy. We'll see why. 82% are DT. Why 82% are DT? Because now it's easier to get a heart if you get an Impella or a balloon pump, right? So bridge to transplant category mostly disappeared. This is if you take all the patients who had a continuous flow device, so it's HeartMate 2, HVAD, or HeartMate 3, there's a 5-year survival of 47.3%. But if you look at HeartMate 3 and the green line, it's 63% survival. So that's very similar to what I just showed you in Momentum 3 trial. What about adverse events? Well, again, train your eyes on the green line. That's HeartMate 3 compared to the others. Much less GI bleed, much less pump thrombosis. That's probably the most important benefit of HeartMate 3. Much less stroke. If you don't have a stroke in those first few days after surgery, your baseline rate is the same as a heart failure patient who doesn't have a device. Where we have not made a difference is in driveline infections. And this is the Achilles heel of this technology. HeartMate 2, HVAD, and HeartMate 3 all have the same incidence of driveline infection. Well, we're very United States centric. What's happening in Europe? And DR is here. And DR is actually part of this. The Elevate registry, which basically follow people who had a durable device for 5 years. And there's DR as the senior author of the trial. And you see 63.3%, almost exactly what we found on Intermax, actually exactly what we found on Intermax. So there's consistency. This is true. This device provides a very nice long-term survival. And you see a significant amount, but not all, are either class 1 or class 2 heart failure at 5 years. So what else is exciting in the field? Well, it came to questions, can we throw the aspirin away? As you know, people who get a HeartMate 3 have to be on Coumadin with 9-hour 2 to 3 and our baby aspirin. We're seeing a lot of bleeding events. The device itself causes an aspirin pathology, namely von Willebrand's disease, which makes the platelets not as sticky. So the question came, well, if we're causing what the aspirin causes, do we need to give aspirin? And can we do that safely without increasing the risk of thrombotic events? And that was the ARIES trial. And here it is. And again, Uli, Omar, and myself were part of this landmark trial. And again, the primary endpoint was survival-free of major non-surgical hemocompatibility-related adverse events, so bleeding or thrombosis at 1 year. And you see, these are non-inferior studies, so not a superiority study. And people who got the placebo, i.e. something that looked like aspirin, it was blinded, did better in terms of the outcomes of the primary endpoint. And that was largely driven by bleeding. So there was less bleeding as you would expect. And the people who did not get the aspirin got placebo. The question is, well, what happened to the thrombotic events? So if you look at adverse events, again, all the point estimates favor placebo. So you didn't get aspirin, you didn't bleed as much, all kinds of bleeding, moderate, severe, GI, epistaxis, etc. And in terms of thrombosis, which is the safety part, it was fascinating. Actually, the patient did better who got placebo. So this is a huge event on the field. And almost overnight, we stopped giving aspirin to all our new implants. And if you look at particularly subgroups where they're diabetics or people who have ischemic etiologies, and then if you think something very interesting, people with coronary stenting, CABG, AFib, pump stroke, prior stroke, and history of thrombosis. Those are things that you want to give aspirin to, right? These are people we normally give aspirin to. People who did not get aspirin did better. You look at the point estimates on that forest plot. So this is pretty cool. So the conclusion of this trial was avoiding aspirin is not inferior to an aspirin-containing regimen. Decreased events were seen without a cost in thrombosis. And for every 100 LVAD patients, we had 14.5 less bleeding events in 1 year, 47% cost reduction, and reduction in days out in hospital, and significant reduction in costs. And importantly, this was seen even in people who had a stent, who had a stroke, who had peripheral vascular disease. Now, what ARIES does not answer, however, is what about those people who had a HeartMate 3 device, are walking around at home? Should we stop aspirin on them? That question has not been answered. Number two, is there a cohort that we should give aspirin to? And number three, very important, this is a 1-year study. We don't know what's going to happen. And I shared a paper with Snehal and Uli last night. They came out of Colombia that shows that 10% of HeartMate 3 recipients are getting aortic root thrombosis. So that might be a concern. So we have to look at that data as well. What about LV recovery? Is that a myth or reality? So basically what we have is we have a dilated LV. You put a HeartMate 3 in. There it is. Now you see early reverse remodeling. You see the heart getting smaller. And here, full reverse remodeling, the heart looks normal. And I want to shout out, there's 3 people who are really leading this field in the world. And one of them is Snehal Patel. And the other 2 are Emma Burks and Stavros Drakos at Utah, who are really pushing this field forward. So LV recovery during LVAD support. Number 1, it doesn't occur if you don't look for it. And most people are not looking for it. They put the LVAD, they go home, let's wait for a transplant or live out your years with your LVAD. And it's important to recognize that while some people recover histologically, LV function doesn't necessarily improve. There's a disincentive to diagnose it, which goes back to number 1 bullet. Why is there a disincentive? Why do I say that? Because programs want to do more transplants. Hospitals want you to do more transplants. So if you take an LVAD out of someone recover, there's 1 patient that's going to get a transplant. So there's a financial incentive not to do this. It is labor intensive, and I'll go over that a little bit. And people who recover, we're not sure what to do. Do we put them through a huge operation to remove an LVAD? That's not a fun operation. Or do we deactivate it? What does that mean? We cut the driveline and we suture the outflow closed, which is a minimally invasive procedure. We at this institution favor the latter. And there's understanding these people are going to be lifelong on GDMT. And comes the concept, is this really recovery or is this more like cancer? Is this remission? And I think remission perhaps is a better term for this. So the science has evolved. We can now identify people who have the phenotype that LV recovery might happen. Who are those? Young people, non-ischemic, low creatinines, not huge hearts. And we now have a process how to think about each of the steps, the pathway, the journey the patient takes to recovery. First, well, we've recognized a certain phenotype. How would we manage post-implant while they're in the hospital? What do we do after they go to the hospital? How do we introduce GDMT? And that's been the subject of many prior talks here. How do we start getting echoes? What do we look at? Explant testing, that's really very labor intensive. You have to put the patient in the cath lab, you put a right heart cath in them, you do an echo, you do bicycle testing, you occlude the outflow graft and you turn the LVAD off. So this requires a lot of work because you really want to make sure that if you're going to take the LVAD out, you're going to be successful, at least early on. And then what happens after you've taken the device out or deactivated? And this is a very nice chart showing the details of the process I just mentioned. And this has led to a change in the way we should, although we don't always do this, the conversation with a patient who's in the ICU and CCU North 6, and they're inotrope and million dobutamine and maybe a balloon pump, and you say, this is the LVAD. Do you want this, the drive line, or do you want a heart? You can win the lottery. You're going to live forever. So in young patients with end-stage heart failure, I don't think we have balanced discussions with them in this regard. And now that we have this information that the recovery is possible, particularly in young people with non-ischemic cardiomyopathies, we need to be more transparent on the benefits and risk of LVAD versus heart transplant. And this whole idea of a net prolongation of life comes into play. You can be a 22-year-old and get a heart. I won the lottery, and your median survival is 12 years. So yeah, you went from 22 to 34. Not so great. If you're 68 and you go to 80, that's pretty good. So in young patients, the conversation, well, should they have an LVAD first? We now have pretty good 5-year survivals, and then you get them a transplant. So you've prolonged the life in this earth by putting an LVAD first and then a transplant. It is very hard to get a second transplant after a first one. It is easier to get a transplant after an LVAD. And something we haven't done before that I think the field's evolving to is when we have these conversations with young patients, when you say you might have, if you get an LVAD, there's a chance your heart might recover. So you might have your own heart. You might live your own heart. So very important. So what does a pipeline look like? This is the only device available in the field, the HeartMate 3. There's a monopoly. That's not good in any economy with anything. But unfortunately, that's the way it's been for the last 4 or 5 years. And what happens when there's where that kind of situation? There's no incentive to innovate, right? So there are a lot of pragmatic reasons to have new technologies. One, competition to advanced technology, which has not happened in our field. There's supply chain issues were really a little less important in LVADs. The hardware, became a no device a few years ago. Competition may reduce costs, although I'm very skeptical about that. But perhaps more important, competition may increase clinical engagement. I think that's very important. We need to switch from thinking of survival, now that we have pretty good 5-year survivals, to patient-centered quality. And what I mean by that, we need to reduce the adverse event burden even further. One of those things is things that I've already mentioned, bleeding, stroke, infection, right heart failure, volume overload. The best way to engage heart failure cardiologists and patients to this technology is to make those things better. So how do you make those better? Well, what are the gaps? One, we got to get rid of the driveline. This is not a sexy thing to walk around with, right? It's just not nice to have this thing coming out of you. We need durable options for right heart failure, left ventricular failure. I don't know if my colleagues agree with this, but 3 out of our last 5 LVADs are required in RVAD. And I don't know if we're seeing a sicker prototype. I've spoken to other people. I don't know if that's your experience with LDR. We're seeing more need for BIVADs, and we don't have a good option for that. Same with biventricular failure. We need to further reduce HRAEs. We need to reduce invasive surgical procedure. Yes, some will have to do it minimally invasive, meaning still a big thoracotomy and a big sternotomy. These are dumb pumps, really dumb. They don't do anything except pump. They don't sense your ICD or your pacemaker. They're not reactive to your physiology, whether you're sleeping or running. You can't remotely, telemetry like you have with a pacemaker. And there's a lot of still caregiver and patient burden of care. So these are the technologies. These are the 5 technologies that I see are probably the brightest in the field. EvoHeart is a Japanese pump. And if you can see what they're shooting for is less shear stress, increasing flow pulsatility. The CoreWave is a device, it's interesting, designed to propagate blood like a fish tail. So it's very gentle in the blood, not like a spinning centrifuge. And again, reduce shear stress, which likely will lead to less hemocompatibility-related adverse events, and also improve aortic valve opening, which might lead to better GI bleeding and less aortic insufficiency. The Brio device is a Chinese device. It looks very much like HeartMate 3. It's one that we hopefully to be involved in a trial and hopefully will start soon. And again, you see shear stress, better peripherals, more pulsatility. The Torvad, that's a American pump, is the only one that I know of that has pump speed adjustment adjusted to physiological needs. And the FlowMaker, which has just been put in first in human in Prague, is a device that's transcutaneous energy transfer technology, meaning there's no drive line. It's completely intraventricular device. There's also improvement in total artificial hearts. I've shown this many times. This is the best. This is the best and only total artificial heart we have. It gets stuck with Velcro, right? This is 1980s technology. It was called the CardioWest, the Jarvik heart, the Syncardia heart. This is still what we have. And when you put it in, you have to put a breast implant as well, because the device can move, so the breast implant sort of keeps it in place. We need to get rid of this. And there's maybe 50 or 60 devices placed a year. This is not a consequential device anymore. So you see two devices, the Bivacor device on your left and the CarMat on the right has been placed in several patients. The key to getting rid of the driveline is having a reliable way to transfer energy to an implantable battery, right? And this is not new. This has been around for 30 years. The Lionheart, the Abucor Total Artificial Heart, and the Jarvik LVAD all had this, or some form of it. The Fine Art is that last device I talked about, it has it. And here's sort of the two Jarvik patients. The black thing you see on the right looks like a bra. There's a transmission belt that the patient wears, and there's this energy source that they carry here, and they can transmit energy to an implanted coil that powers the LVAD. Two patients had the device. And the beauty about those devices, of course, is the patient can do that, right? Which they can't do with any other technology, submerge themselves in water. So what are the next frontiers? And I'll close with this. Percutaneous LVADs. So LVADs to go. I think this is where the field is moving to. One device is a Procyon aortic device. It's a percutaneous device. It's placed up the femoral artery into the descending aorta above the renals. And basically is a flow accelerator. Sort of sucks down, much like a balloon pump does during systole. Sort of sucks down, improves blood flow distal in the distal aorta. Device is a quarter shape, quarter size, easy to put in. A patient can go home. This is in clinical trials. The New Pulse Voyage device is an implantable balloon pump that people go home with. You have those leads, EKG leads, and there's a little button. And this is not a mandatory device. It's very cool. If you're going to go out for a walk, you connect yourself and the balloon pump starts working. And if you're going to sleep, you take it off. So that's an interesting technology. And finally, there's the new version of the Abiomed device, right? Everybody's seen the Abiomed 5.5 device. That's that device, right? From Abiomed that can flow 5 to 6 liters per minute. There's a version of this device where the patient will go home with this device. And that's in clinical trials as in the midst of an early feasibility trial. The first 10 patients are not going to be sent home. It's just a proof of concept to make sure it's safe. And the next iteration of the prolongation of the trial, these people will go home. So if I take you sort of my photo album, what's happened? First generation devices, 1998, 2006, HeartMate XV. You did not get pump thrombosis. You did not get GI bleed. You did not need Coumadin. However, device too big, too noisy, limited reliability. They all failed within a year and a half. Second generation devices, HeartMate 2 and HVAD, small, noiseless, reliable, but you have pump thrombus, you have GI bleeding, you have AI, you have CVA, particularly the hardware device. Third generation devices, the HeartMate 3, small, noiseless, reliable, no pump thrombus, 5-year survival, but you still have dry lung infections, no physiologic responsiveness, and we're still seeing aortic insufficiency and right heart failure. If you ask me what the future looks like, fourth generation, 2026 onward, I don't know what this device is going to look like, but it'll probably be a version of HeartMate 3. Some people call it HeartMate 4, others HeartMate 10. It'll be smaller. The peripherals are going to be smaller. It'll be minimally invasively placed because there'll be facilitating technologies. The incision is going to be smaller, and there'll be the ability to pulsate the device. You're still going to have a drive line. I don't think it's going to be before 2030. And DR, I'm curious to see what your thoughts are. The utopic device. It's not going to look like a pacemaker, but in theory, it's going to be like a pacemaker. And what I mean by that, it's going to be physiologically responsive. You can monitor remotely. It'll have TETs. It'll be considered an alternative transplant finally, and it'll be forgettable. So I started with excitement, and I'm going to end up with some excitement. Last month at NYU, surgeons put a HeartMate 3 device into a patient in dialysis with end-stage heart failure, and then 10 days later brought him to the OR and put a pig kidney into her. Unfortunately, this started well, but the patient had to have the kidney failed. Why? Because there was a lot of up and downs, as you know, management of the HeartMate 3 device, perioperative, a lot of hypotension, swings in hemodynamics, and that affected the kidney, and eventually the kidney failed. But at least as an insight into what might happen in the field, it might be exciting. So thank you very much.
Great, thank you. That was really outstanding. Any questions from the audience? Oh, Steve, I'm gonna bring you the mic.
Good talk. Seeing this updated version every year, so I was excited and I learned a lot. But when we have a trial, comparing transplant to a device, your communities are.
Yeah. The problem is that the trials are really difficult. Because now they can put down what we want. The parents are going to be willing to make positive fail. So how do you deal with that period of time when it's very nice experience when you're not able to think? It can be done. I'm curious more about our heart movements and how what do you think about that? It's a great question. All the available to me. Is there any points? I don't think there is.
There's any bot study going on in Europe forever.
What that?
Every bot study was comparing each 4 patients. From it's going on since like 20 years.
Yeah, because you don't have individual endpoints, for the patient.
Thank you. So it's very comfortably randomized, but still there's a so-called early bot study. I've been hearing this since last 15, 20 years. Recruitment is really, really tough. It's going on in Berlin. So what they do, they have stable intermax 4 patients. They are listed for transplant, and then they will get randomized. Some of these patients will get LVAD, although they are not like intermax 3 or 2. And some of them will stay on the T and will get transplanted. And this study again, they have a lot of problems with equipment, but still it's kind of converted to outcomes.
Any big trial on trying to avoid warfarin use, Noah,
Yeah.
like, because if that is the case, we mainly use the lower dose than the one that we use for patient, something that maybe fail, that amount.
We are friends of Ivan Tuchel smoking here. Just published some early experience with using donuts after a period of 2 minutes plus aspirin, and you stop and start with donuts. And I think there's a signal that it may be safe, but I think it's
Yeah, there was but Danny showed that the HAPME3 is so much more hemocompatible, right? Really no thrombus. And the older pumps, HVAD, HAPME2, DOACs were tried and really failed basically miserably. So in Prague, they just showed it at the last meeting at ISHLT, but also happened to be in Prague. And there was an early signal of LDH elevation, which was kind of the canary in the coal mine for the HAPME2 in the past, that hemolysis is happening and things will go down. And then we haven't heard anything since. So I think this doesn't seem to be working. So we're going to just switch the debates. We're going to start with the LVAD debate, LVAD versus transplant, because that's just flows better right now. And I just want to have you look at this beating heart, and want to thank Julio Valle, our research fellow, who's going to be a cardiology fellow in Tulane soon, for making the slide template and makes everything really nice. Right. So the question is, and unfortunately we didn't have the ARS. So we have a 48-year-old man with inotrope-dependent heart failure. You heard Dr. Goldstein show you impressive data. We can either have LVAD next week or wait for a transplant. So let's do a vote. We do yes, no, abstain. So everybody has to do something. Okay. 48-year-old man, inotrope-dependent heart failure, LVAD next week. Raise your hand. I didn't tell. Good question though. Okay. Wait for transplant. Okay. And abstain. Abstain. Nobody raised their hand. Okay, very good. So you saw the HAPME3 already. It's a beautiful device that we like to use, more hemocompatible, just a better technology. I have to give the disclosures. So we talked about the 12-minute study. I was the chair of the clinical events committee, and in that context, reviewed almost all cases and received a small honoraria, but have none since August of 2022. I'm the system director of advanced therapy, so whether we do a transplant or an LVAD, doesn't matter to me. Every therapy that saves a life is a win for me. Dr. Patel, who is going to be my opponent today, is the director of the transplant program. He wants to see more transplant to increase the status of our program. He's already led the heart transplant program to #1 outcomes in New York at 98.75%. But he's just greedy. He can't get enough. He also wants to have the highest volume in New York. So these are our disclosures. I don't know if Snehal has other disclosures later. So here's our case. A 48-year-old man with non-ischemic cardiomyopathy, diagnosed only recently, genetic workup negative, couldn't tolerate full GDMT, eventually dependent. He's blood type O, 6'5", 250 pounds, and highly sensitized. So everybody who has a little bit insight, this is the drop the mic and we're finished here. And I will explain to you why that is. But this is one blood type. So just for background, blood type is important in transplant. If you're a blood type, if you're a recipient with an AB blood type, you can get any other blood type, AB, AB0, O, I mean, that it doesn't matter. If you're blood type O, you have to have an O heart. So you're already disadvantaged. The other thing that matters is how big you are. You more or less need a donor within 20% or so of your body size to go forward. So then there is the allocation system that Dr. Goldstein mentioned that has 6 strata. First strata is VA ECMO, non-dischargeable surgical implanted BIVAD, LVAD with VT. And for another disclosure, Dr. Patel provided me with a slide previously. Then there's status 2. You have to have an implantable, an IABP or an Impella or a non-dischargeable surgically implanted single VAD, or you have a complicated VT on IV. Status 3 is a 30-day discretionary time for an LVAD, significant LVAD complications, PAC and Arnold-Hobson CCU. The way this works is if a heart comes up, it is first offered to all the status 1 patients within 500 miles. If nobody takes it, it goes to the status 2. If nobody takes it, it goes to the status 3. And if then still nobody takes this large O donor that we're looking for, then it goes to status 4, which is our patient. And here's Dr. Patel. I put the photo because it's actually his slide. So we're looking for a donor that's at least, what's that? Dr. Patel is status 7, I think, right now, but we're looking for a donor that's at least 5'11", at least 200 pounds, is blood type O, and there's no competing recipient within 500 miles in status 1, 2, or 3. And that's, that's the microphone. That's not going to happen, but that would not be fair. So let's make this different. Let's take a donor that is blood type A, which would be me, that is 5'10", which I would like to be, but I'm almost, and it's 172 pounds, which I am. And I don't think I'm sensitized. So what if I needed a transplant? I'm a little bit older than 48, but I can probably fake it. I want my heart to recover, right? Danny showed you nice data on recovery. The first discovery was described in 1966 by Michael DeBakey, who you see here, who eventually died at age 99, I think, from an aortic dissection. 1991 was the HeartMate 1 device, patient recovered. 1994, a few explants. And this has really come a long way. There's a large experience. This is a paper 10 years ago of many centers, including Montefiore, reporting percentage of recovery when they approached it prospectively. And here you see my opponent. I'm trying to build distrust for Dr. Patel in making the case for transplant. This is probably the most important recent paper, the Restage Heart Failure Study, where 40 subjects were included. They had NICM, just like our patient, low EF, large heart, a little bit younger than our patient, short duration, just like our patient, were treated, and the pumps were optimized. They were actually able to explant a very significant number of these patients and recover them. This was just an initial study. And of course, here's Snehal, again, in 3rd position, slowly making his way to the top. At ISHAT 2024, when there was an international consortium update for LVAD recovery with, I think, over 360 patients that showed very similar result, excellent chances of recovery in the right patient, and presenter and first author, of course, Snehal Patel. So if he tells you something later, take it with a grain of salt. You already saw this. We have gone from bad pumps to pretty good pumps. You also already saw this. It's almost exclusively HeartMate-3 right now. The hemocompatibility of this device is much better. And you also saw this, and you showed that in the real world right now, you just talk about survival. Our patients who's 48 years old in INAMAX, in a real world database, has a 5-year survival of 76%, which rivals transplant, might be better. We don't know, but certainly it's an equivalent therapy. So for my part of the debate, given the current technology, given the fact that we might have to wait for a long time for transplant and work our way up in the allocation system to get sick, there's only one answer here for a patient like this, and that is to do an LVAD next week. And then we send him to Snehal's clinic because that's the best chance for him to actually recover on the LVAD. So I'm handing it over to you now.
Well, thank you, Uli. That was great. I'm going to go ahead and start by saying that I'm a little nervous to do this debate. I have been nervous since this came out because of who I'm debating. I'm debating Dr. Yordi, and apparently I'm debating Dr. Goldstein because he was making the case beforehand too. And Dr. Yordi's been a colleague and friend for almost 10 years, but a mentor, both personally and professionally. And he's my boss, so basically he writes my checks. So this is a little bit intimidating. So when I was thinking about this, I thought there's really two ways you can approach a debate. You can debate the topic, or you can try the way they do in the political system, which is to debate your opponent. But I think that the professional way is really to stick to the topic, and that's what I'm going to do to make it easy for myself. So this is the case. What? Save the check. Yeah, save the check. Yeah. It's a 48-year-old male with non-ischemic and inotrope-dependent heart failure. And there's not really much detail here, and Uli purposely left this open, but I think we can glean a couple of things for this. First is that he clearly has end-stage heart failure. And because of that, he's going to have a mortality benefit from one of two therapies, which is either LVAD or transplant. The question is, which is better for him? And better is a tricky term to describe. And the way that I go about this in my clinical practice is I try to put myself in that patient's shoes and imagine what would they want. So let's put ourselves in this patient's shoes and imagine ourselves as a typical 48-year-old male, a suburban dad who lives in New Jersey. And after he gets home from work, he has to unwind and he likes to do exercise, adventure stuff. And you have to ask yourself, if you were this 48-year-old man and you like to ski, could you ski with the LVAD? And the answer is probably not, because you fall, it gets pulled, it gets tugged, there's a lot of danger. So I'm going to say he can't do that. Other times he likes to stay fit, so he's on the elliptical. Can he use an LVAD at that time? That's also going to be a little bit dangerous if it gets pulled or not. And probably the most important thing is that in the summer he likes to swim. So if he has an LVAD, he can't do this. And Sasha tends to be a scholar of history, and this was written by Seneca. It was a moral essay. It was very short, but he talked about the shortness of life, and he says, as is a tale, so is life. Not how long it is, but how good it is what matters. So it's quality of life. So I could tell you and just stop right there and say, for that 48-year-old male, an LVAD is not a good option. But let me kind of go through some of the stuff that Uli brought up and really tackle them, because I think objectively there are really three possible arguments to pursue transplant prior to heart transplant, pursue LVAD prior to heart transplant. One is that the wait time for heart transplant on temporary MCS, which is really what you need to get to transplant, presents a hazard that is greater than an immediate LVAD. The second is a chance for myocardial recovery on LVAD support. And the third is this concept that Danny brought up, which was net prolongation of life, right? So if you have if you understand the fact that heart transplant is not a cure, but an 11 to 13 year extension of survival, wouldn't it make sense to delay the clock and start with LVAD first before you move on to transplant? So let me break those three down. So the real world data demonstrates that the risk of waiting for heart transplant on temporary MCS is low. This is data that was published in Journal of American Cardiology a couple of years ago. It looked at real world data from UNOS. And what it showed was, what is the chance, if you're waiting on a balloon pump, of dying or getting so sick that you get delisted? And it's 6.9%. It's certainly not negligible, but if you consider what the risks of LVAD are, 10 to 15% at 1 year, this seems not unreasonable. And if you look at what we've done at MonteHeart since 2019, we have bridged 46 patients to heart transplant on temporary MCS, and only one has died or been delisted. And that circumstance was actually a little bit unusual. That patient we had an accepted offer for. We took him to the OR, he got anesthesia, but our recovery team felt that that heart was not good on visualization, so he was extubated, and it was the whole anesthesia process that decompensated for him. So I will argue that waiting for transplant on temporary MCS is less risky than it seems. I'm going to skip through this a little bit. This is what Dr. Goldstein brought up about recovery. This is the ICAR score. And I'm not going to argue with this. If you have a high probability, and by high probability, I say more than 10% of recovery on LVAD support, those people should be offered or at least considered for LVAD prior to heart transplant. There are a number of these scores, and we have to use those to try to understand what to do with our patients. A newer one that's come out that's probably a little bit better than the ICAR score is this calculator, and it gives a personalized assessment of what your chances of recovery. I think if we plug this in and it's more than 10%, that makes a lot of sense. Now, let me tackle this last concept, which is definitely intriguing to me, and this is the idea of net prolongation of life. So you could be of one or two strategies here. The first is primary heart transplant, and you live 11 years. The other is that you live on LVAD for 5 years, and that's when you start your transplant clock, and then hopefully you get to 16 years. But there's a couple of major assumptions with this, which is really just a hypothesis. One is that you're guessing that 100% of LVAD subjects survive 5 years, which is not necessarily the case. And the other is that the outcomes for heart transplant recipients bridged from LVAD are equivalent to primary heart transplant. Let me just take you through some of that data. This, of course, is data we've seen from both Danny and Uli. This is Uli's first author paper on the Intermax report, looks at all LVADs put in the country. And this is really about perception. So green is the HeartMate 3 line. Well, there are a lot of risks. 10% CVA up to 5 years, 30% chance of device infection, 25% of GI bleed, and 15% of device malfunction. Certainly better than the prior devices, but these don't sound like very friendly numbers when you're trying to choose a therapy. And when you put this all together, the 5-year survival is 63%. So just keep that in mind. That's not a bad number for somebody that doesn't have another option, but in terms of net life prolongation, it may be a little bit concerning. The second thing is that if you're on an LVAD and then you go for transplant, we know one of the biggest negative risk factors is having a prior LVAD. So one of the dreaded complications after heart transplant is primary graft dysfunction. And that's when the heart doesn't start afterwards. There's a lot of different potential etiologies for it. But if you look at the biggest risks for it, and this is from a large registry looking at PGD, it's LVAD. We're talking about nearly a twofold increased risk in this multi-center registry. And when you add this up and you look at the ISHLT registry, which is 50, 60,000 patients, what is one of the strongest risks for 1 year mortality after LVAD? And sorry, I get if you go down one, it's actually the LVAD device itself, which is close to being on dialysis, ventilator, or even being sicker. So I would say that I can make up curves too. And if you put the blue line here, which is the HeartMate 3 and the Intermax report, and then you start the blue dotted line, which is ISHLT registry data for transplant outcomes versus just primary transplant, it looks like actually transplant does better. And so until this is really proven, the net prolongation of life is really just that, and that's a hypothesis. So I will say of these three possibilities, I believe that number one is not a true reason. Chance for myocardial recovery, I can't deny that. And for now, net prolongation of life is not the real option. So I will say for now, enjoy life with your heart transplant. Life is short and unpredictable. And the best option for this patient is transplant rather than immediate LVAD. So I'm going to stop there, show you some pictures of some of our transplant patients that are doing really well, some of the stuff they couldn't do with an LVAD. And I will stop there.
Okay, should we do the poll again? I'm going to call it a tie, but who goes for Albert? Living in Europe.
Oh.
You don't want to ask this.
Yeah, no. So that was terrific. I think it was a really great really great presentation of our team. I think the best for any patient is a highly individualized approach where you and I agree and the team what the right thing is, and that's what we do once a week on Wednesday morning. So thanks now.
Rolling down the U.S. perspective here, I want to ask what his thoughts are in terms of what you just heard. The allocation system in Europe are different, the availability of organs is different. They don't have opioid epidemic, and have an opioid epidemic for thriving transplant in this country.
Yeah.
Before you say anything, we have to introduce you. So I forgot. So Diaz Sayed is the professor of surgery and chief of heart surgery in Germany. Was before that at Leipzig Heart Center for a long time, and we all know as well because he's a board member of the ISHT and one of the really renowned bad and cabbage surgeons in Europe.
Well, thanks, Uli, for the invitation. Thanks, Danny. So first of all, let me answer your question. So the answer is very easy in Germany because we don't have this access to organs like you guys here in US. So that kind of patient will survive for a transplant. So that being said, blood group 0 has in the high urgent status has to wait 6 months for a transplant. With that, the patient will never survive. That being said, all of that kind of patient will end up with LVADs. Not because we want to do this, because that's the way we need to do it, and because otherwise the patient will not survive. So it's easy to say. All right. Well, thank you very much again for the invitation. It's a privilege to be here for the second time. And to be honest, this is very unfair. It's like almost 10 p.m. in Germany. So it's the time to go to bed now. So now I'm debating Danny Goldstein on this time of the day. So it's really unfair, but I'll do my best. So what the whole deal about? So I have nothing to disclose regarding to this talk, except for one thing. I'm a minimal invasive surgeon. So almost 70% of the procedures I'm doing is minimal invasive. I barely open up the sternum, including all kinds of procedures, including tumor surgery, mitral, tricuspid, double valve, aortic, even like we do Bruntel procedure, doing minimal invasive procedures. So what the whole deal is about? We have a 65-year-old man with 3 vessel disease. He has a viability. This is very important. So we have a viability in MRI. Ejection fraction is 15%. So I will be for minimal invasive cabbage, and Danny will say, no, let's put an impella in and then do a cabbage. Well, we'll see. So the first question I would ask here is this patient in shock? Is he having any shock signs or symptoms like low blood pressure on pressors? Is the patient having RV dysfunction? Is the patient having pulmonary function tests? If that all of questions been answered no, and we have none of the sign of the shock, then the answer is very easy. Just do a mid-cap. We're done. Actually, I need to drop the mic now. So why mid-cap? With mid-cap procedure, we don't use cardiopulmonary bypass machine, no CBP. There is no cardioplegia. It's a very quick procedure. There is a fast recovery. We don't need to do any incision for the subclavian artery because you have to do a procedure to implant an impella in. To be honest, I do a lot of impellas as well, but in that kind of a procedure, I don't need to do it. And by the way, the patient will have like a 4 or 5 centimeter incision and will be discharged like 5 days afterwards. So that being said, mid-cap is the way to go. What's the advantage of impella if I would do impella? Impella has the advantage probably that I will avoid times of low output syndrome. You know, the bad thing, if you do an OPCA procedure and the patients get in crash and you have to go on CBP like on emergency patients, that kind of patient, they do really bad afterwards. So that may be the advantage if I would have Impella in the patient, so I will not have that kind of a problem. But again, what are the disadvantages of Impella? Well, bleeding complication. I mean, I don't know how many times, Danny, you did an Impella in a cabbage patient. So back in days when we were doing Impella 5, we had the patient Impella includes heparin. So the patient got out of the OR with a high ICT value, with a high PTT, they will go back to the OR for bleeding complication. With that kind of patient, that's something to have. Stroke complication, another question. Infections, increased procedure duration, of course, because you have to spend like 10, 15 minutes here, go through the aortic valve, and then subclavian and artery injury. Not much people are talking about this, but this is a problem that one of the patients that they get an Impella may have that problem. So, and that was published back in 2019, that there is a lot of complications related to Impella. Why shall we do this? There's no reason to do this, yeah. So the first question, is there any paper or study comparing Impella plus cabbage to a minimal invasive cabbage? The answer is no. There's no paper around published comparing these two procedures. So what I will do now, I'll try to do my best convincing you why off-pump for halfway patients is better and why minimal invasive procedure is better for all patients, particularly the halfway patient. And I will give you some thoughts about what I mean when I say I'll do a mid-cap procedure. So let's talk about off-pump versus on-pump. I'm an off-pump person. So when I do a procedure, cabbage, I always do off-pump. But again, off-pump comparison between off-pump and on-pump cabbage, there is tons of papers out there. Still, it's a European-based procedure. So in Japan and Europe, particularly in Germany, we do like 25% off-pump. US off-pump procedure is not that popular. And all of the papers comparing off-pump versus on-pump. Again, off-pump means that you do a procedure without using heart-lung machine. There are conflicting outcomes and papers. And I picked up two recent publications. One of them obviously from Germany, and the other one is from Japan. They just look at patients with low ejection fraction, and they found out that patients with off-pump cabbage with a bad ejection fraction, they do better, they require less ECMO, and they have a trend toward a better outcome. But again, there are a lot of people that don't like off-pump procedures. Why? There are concerns about the bypass patency long-term, that the bypass may not stay competent. And then the so-called incomplete revascularization. People's not experiencing off-pump procedures, they tend to do less bypasses compared to on-pump procedures. Why is that? I'll show you a video and you'll understand why. So, but there, if I would kind of summarize all of the off-pump procedures, you kind of figure out that all of the off-pump patients, there are studies showing that lung pulmonary function, renal function, strokes events, AFib, where's our AFib guy? The patient who will get the patient after off-pump procedure will get less AFib complications, less bleeding complication, and patient with bad ejection fraction will get a best outcome out of this. So this is the patient I did 2 weeks ago, 20% EF, but viability. The way we luxate the heart, you can see here in this video, you see the LV is barely moving. But again, that kind of patient, you should make sure that the patient will not crash in OR because his outcome will be much worse. So we talk about off-pump. So why I'm talking about off-pump? Because minimal invasive mid-cap is an off-pump procedure. So we don't use heart-lung machine for that. Let's talk about generally minimal invasive. There's a lot of papers out there comparing the minimal invasive procedure to sternotomy procedures, and they all have one in common: reduced blood loss, better respiratory function, less wound infection, early mobilization, quicker recovery, and facilitation of the reoperation. If I have a patient status post minimal invasive mitral valve, the patient will operate on later on as sternotomy. It will be a much easier procedure, and better cost basis, of course. Another point. So how we do mid-cap? This is like a video for, I don't know how many surgeons are sitting in the room except for Danny. So the way we do this, the patient will be elevated like 30%. And then this is
the incision, and the first thing I usually do, I look at the LAD. Patient with heart failure, they will have, I look at the X-ray before or a CT scan. I have to make sure that where's the LAD almost alive. You may end up doing the incision a little bit further towards left if the patient having a bad ejection fraction. So I'm going to fast forward. So this is the preparation. This is like the toughest part of the procedure, to prepare through this little hole, the lima. You need to have a single lung ventilation. That's why I told you the patient need to have enough and optimal pulmonary function. And then that's what's happening. This is the lima, and then pericardial traction sutures. And then we look at the LAD. I'm going to fast forward a little bit. And the heart is beating. That's the nice thing about it, you know. You don't stop the heart. You don't give any cardioplegia, and you do not luxate the heart. If I would do this procedure, sternotomy, I have to luxate the heart to see the LAD, because the LAD is looking to the left. But for this procedure, the heart is staying as is, you know. We open up the LAD, we put a shunt inside. So that being said, when I will do the procedure, the heart is still getting perfused with blood, you know. And then we do the anastomosis. And then afterwards, we do some sort of, this is the lima LAD in place. We do flow measurements. Where's the flow measurements? It's coming up. And then we close the pericardium. We do some pain therapy, chest tube inside, close the chest, done. That's it. If you guys need more details on this, especially for surgeons, there are details about this. We just published that recently. Unfortunately, this video is not playing what we sometimes do, but not for heart failure patient, not for patient with the bad ejection fraction with the high LV/LVD, that we kind of harvest right and left mammary artery through the same incision. With that, we don't have a problem with the so-called sternum wound infection. So that's the configuration we do. If we do more than one bypass, we do a Y graft. We sometimes do a T graft, and then we do more than LAD. We do more. We do a diagonal branch or intermediate branch. So what are the best patient who needs will get a mixed cabbage or the so-called mid-cap? Males are easier to be done. Body mass index should be okay. And if you look at the chest X-ray, the cardiothoracic ratio, this is obviously is important for patients who need more than one bypass. And the LV/ADD less than 50. But again, if you just do a lima LAD, you're good to go. And the lung function is very important. And this is about the RETA. And you have to have, of course, good coronary targets. It's a hard team discussion. Contraindication, if you have a occluded left subclavian artery, obviously you cannot use the lima in that patient. And if you have a shock patient, so any patient in shock, in my opinion, does not need to go to OR. He need a hemodynamic support, he need a mechanical security support, and severe COPD patients. So my favorite thing is the hybrid procedure. That's what we do a lot in Germany, and especially in our heart center when I started like 1 year ago there. What that means that we do lima LAD and the cardiologists do the rest. How we do this, there are two ways of doing this at the same time in the hybrid room or stage. I prefer the first one. We do lima LAD. The patient will come back after 2 months and the cardiologist will see my lima LAD, and at the same time will kind of stent the rest of the vessels. A couple of publications just to show up. This is our Leipzig experience with mid-cap procedures, 0.8% mortality, 20-year experience. Another study, particularly looking at a high risk patient population coming from New York. This study, interestingly, it's like 37 patients with primary mid-cap and 90 patients with reoperative mid-caps. And the outcome was very favorable for mid-cap procedure, but in these patients with low ejection fraction. And the largest study published so far is from University of Chicago group. They looked at more than 100 patients. In this patient was operated on robotic. They were not doing mid-cap only, they were also doing robotic procedures. And in this patient, they saw that patient with low ejection fraction, they have very good outcome. The expected mortality in that paper was 4 times higher than the observed mortality. The only thing which I was concerned about this paper is that the completed operation was median time of the operation was 256 minutes. In my opinion, it's a long procedure for one bypass. And that's the drawback if you do a robotic procedures because you will spend more time harvesting the lima. But this is like last week, or actually it's Monday 27th, 2 mid-cap cases in our horizontal, we were done by 2 p.m. So that being said, it's a quick procedure, 1.5 to 2 hours, skin to skin, and the patient will be extubated most of the time in the OR. So this is one last slide showing the example of a patient is exactly similar to this one, but he's 67 years old, the patient with mainstem disease. And then he was really very sick, not in shock. What we did Lima LAD. 2 months later, the cardiologist did that, and then did the mainstem and marginal branch stenting, and the patient was discharged home in a good condition. If I would summarize, OPCAP is advantageous in patients with low ejection fraction, yes, but only in experienced surgeons. There are not, I mean, this applies for every procedures. Any experienced centers will do better, but often procedure is particularly important. And there is a very nice paper from John Puskas and Gaudino. They look at a meta-analysis. They found out any surgeon doing less than 48 OPCAPs a year, and any center doing less than 150 OPCAPs procedures a year, they don't do well. So having a center with more than 150 procedures, because often procedure as a surgeon, you're not alone. You need to have a good anesthetist taking care of your patient when you luxate the heart. So that's a very important thing, and experience is very important. Minimally invasive procedures are safe, yes, in good hands. Advantage, less blood products, faster recovery, shorter hospital stays. Disadvantages is just technical challenge. You need to get used to it, and it's easy afterwards, and it's a learning curve. Hybrid procedures are best from both worlds, and if you have a shock patient, I tell you, just call Danny. He'll put an impella in. That's it. Thank you very much. Danny, happy to hear your thoughts.
Thank you. Thank you, DR. That was excellent. My disclosures. Funny, we both use boxing. We did not talk to each other before, and this just happened to be. So I think DR forgot about something here. EF of 15%. This is not low EF. This is extra low EF, right? Most of the papers you threw out there quite liberally, low EF was defined as less than 40%. The EF of 40% is very different than the EF of 15%, and most of the EF 15% are big hearts. That aside. So the goals of CABG, unlike PCI, is to reduce and eliminate symptoms, reduce the incidence of future MI, prolong life, improve LV function, and potentially avoid the need for ICD. And that's also hinged on the concept that complete revascularization has to be achieved. Now, about CABG, severe systolic dysfunction. I think it's pretty well established. Dr. Mitchell is one of the co-authors on this monumental study that compared, this is a Stitches trial, that compared CABG to medical therapies, and not PCI, medical therapy, people with severe LV dysfunction. And you see here in the CABG group, compete the medical therapy, it was a win-win-win-win-win for primary outcome and death from any other cause, including hospitalization of heart failure, cardiovascular cause, revascularization, non-fatal MI, stroke, etc. So this established that CABG is the way to go for people with severe left ventricular dysfunction. There's no argument about that. And in that paper, you see that in terms of basically a different demonstration of what I just told you, there's a significant increase in event rate for medical therapy, regardless of how you look at the outcomes. And if you look at the point estimates, CABG is better for any of the subgroups that were pre-specified in that trial. So I think we all agree, DR will agree, CABG is the best option. So DR didn't explain to you what minimally invasive CABG was. He just showed you some pretty videos. Unlike surgery in the belly, minimally invasive CABG means a couple of things. In the belly, it means a small incision. In coronary bypass surgeries, it can mean avoiding sternotomy and or avoiding cardiopulmonary bypass. So avoiding cardiopulmonary bypass is what we call the classic off-pump CABG that he referred to, but that was a sternotomy incision. And you can have a small lateral thoracotomy called mid-cap, which is what he showed you. You can have Lima LAD video or robotic assisted. You can have multivessel grafting. You get total endoscopic CABG, robotic, and you have this concept of hybrid revascularization. I will call Aver Levine here. Why'd you have to make things so complicated? So minimally invasive, you got to know what you're talking. You have to define a priori, what do you mean by minimally invasive? So this is some of the pictures that describe a mid-cap, and you saw it much nicer in the ER's films. That looks to me like a torture chamber. That's minimally invasive? Wow. I mean, look at that. There's like 6 ports, 6 incisions. I don't know. So let's look at the guideline recommendations for minimally invasive CABG. And I looked at all of them. I looked at American, European, Asian. There is no guideline recommendation. It just says other areas in need of further research include the use of non-sternotomy coronary revascularization. This is 2021. EACTS. They don't say much about minimally invasive, but they do say hybrid revascularization is a class 2A for patients who have limitations to traditional CABG. Calcified aorta, poor target vessels, lack of suitable conduits. And it's a 2B as an alternative to multivessel PCI or CABG. So there's no data here to support minimally invasive coronary bypass as a CABG procedure per se. It's a class 2B and pays specific steps. It's experienced centers. And here again, the concept of experienced centers is an important if. So this whole concept of hybrid revascularization is an intriguing concept, and 3 people are happy. The patient, because you gave him a small incision, the surgeon, because he's operating, and the cardiologist, because he's doing PCI, right? So in theory, you'd think, well, that sounds good. And again, there's no randomized clinical trials. The best data we have is from this. Azim was the senior author in this paper, did a meta-analysis of all hybrid coronary revascularization trials. And we looked at perioperative mortality, and you see observational studies on the top, randomized studies in the bottom. And then on the left, hybrid revascularization better, and your right, CABG better. And if you look at periop mortality, if you look at the observational studies, of course, the HCR group is going to do better. When you submit it to a randomized trial, CABG, all the point estimates point towards CABG as being better in terms of perioperative mortality. You look at 1-year mortality, again, the point estimates tend to favor CABG in terms of randomized clinical studies as opposed to the nice observational studies that DR threw out there. 3-year mortality, same thing. Look at the diamond in the bottom. Overall, CABG better. 5-year mortality, same thing. CABG better. So here's a list of the randomized clinical studies showing the minimally invasive CABG is better than conventional CABG for LV dysfunction. Yeah, they're not. What about minimally invasive CABG and severe LV dysfunction? Well, again, there's no large randomized clinical trials comparing any form of minimally invasive CABG, no matter how you paint it, compared to CABG. And there are no evidence-based guidelines by American and European societies to support what DR told you about, even with or without LV dysfunction. He glanced quickly through this, but there's a lot of limitations to minimally invasive CABG and severe LV dysfunction. If you're going to do it off pump, it is technically demanding, and you need to have someone as good as DR to do that. And there are not many surgeons who can do what he does. It is therefore not widely embraced, particularly with robotic approaches. Less than 10% of CABG in this country are done off pump. There is a reason for that. Hemodynamic instability is a big deal, particularly when you have to expose the lateral wall vessels. And it requires anesthesia to be an active player, and you have to have costly hardware to do this. Now, if you have a small incision, as he does, you can only bypass the LAD, maybe an LAD diagonal. You cannot get to the PDA very easily. You cannot get to the OM very easily. And they have to be easy to identify. If you have an intramyocardial LAD, which is not uncommon, that can be a very difficult procedure. And again, as he suggested, it's harder to achieve complete revascularization, which is the ultimate goal. It is very challenging in people who are obese, and in the Bronx, they all are. They have LVH or dilated hearts, which every patient in LVF 15% has. Chest wall deformities like pectus. And as DR suggested, if you have pulmonary insufficiency, you cannot drop the left lung to do single lung ventilation. So there's a lot of reasons why what DR has spoken about is really not very doable. And if you get into trouble, that is a very high mortality situation. You have to very quickly rush into a full sternotomy, bring the heart-lung machine up, and it's full hypertension, etc. So it's quite mortal no matter where you do it. And if that happens, you look like this. That's a lot of incisions. That's not minimally invasive. So why did Uli set this question? What is the fear? What was the goal? Well, the issue here is post-cardiotomy shock, right? If you're going to operate in someone who has an EF of 15%, your fear is that this patient is going to develop a low cardiac output syndrome. So what is PCCS? It is difficultly separating from bypass or developing low cardiac output syndrome after you separate from bypass or when you're in the ICU. And what is the knee-jerk response? Well, you start inotropes, you use dobutamine, you use epinephrine, etc. And just as a historical study, if you leave the OR with 3 high-dose pressors, there's an 80% chance you're not leaving the hospital. All right, so that's important. And who are the patients who are likely to happen this? Patients with EF of 15%. The next thing you do if the inotropes don't work, you put a balloon pump in. Balloon pump doesn't work, you put the patient on ECMO. The outcomes for ECMO plus minus balloon pump and post-cardiac shock are horrendous. 31% of people leave the hospital. So PCCS is something to fear. And me, I'm a pretty conservative surgeon. I want to go into the OR comfortable that I have a way of preventing this or treating very quickly. So why do we talk about Impella in this trial? What in this talk? Well, there's many options a surgeon has to try to either preemptively prevent or treat quickly post-cardiotomy shock. There's a balloon pump. You have something like CP Impella, which is really not applicable to here, a 5.5 Impella or VA ECMO. And if you look at the pressure volume curves, you like your pressure volume loops to go left and downward. And you can see taller Impella is the best option in terms of unloading a sick left ventricle. And if you look at here, you can see that LV unload is maximum with a 5.5, and you get systemic support that is similar to VA ECMO with or without an Impella. So it makes a lot of sense to use a device that can completely capture the cardiac output with a very sick ventricle, and you're at the same time unloading a very sick ventricle. So the Impella 5.5, you've all seen it. Here it is. It's a very small device. It can be placed via the axilla, right axillary artery through a cut down. You suture a graft, and then you put it through, and then you need to be let it up and fluoroscopy to advance into the left ventricle. You can alternately do it without all that. You just put a graft in the ascending aorta and put it directly through the aorta into the left ventricle. One is called direct, one is called transaxillary. And the way we typically use this device is a bridge to transplant in people who are decompensating. So they're sitting on Uli's unit upstairs. They're on Melanone. Danny Sims calls you 2 o'clock in the morning, the patient's crashing. You can put the patient in Impella support. More commonly, something happens with a patient who's on a balloon pump. They're sitting in the bed for 12 days, 15 days. The patient's getting listless. He doesn't want to be there anymore. And you say, well, let's just put an Impella because you can put it here. The patient can ambulate, wait for a transplant. Or they develop ischemia. So these are the typical scenarios where you would think of using this device in cardiac shock. The other was to transition patients from ECMO to allow for more ambulation and recovery, to assess RV function, and to complete the transplant analysis. Remember, a lot of these people come in cardiac shock. You put them on ECMO quickly wherever they are, and then you're sitting on ECMO, and they're going to get coagulopathic, they're going to get deconditioned, malnourished, etc. You can transition those patients with this device, get the ECMO out, ambulate him, and then launch an LVAD transplant evaluation. The other way it's used in people who develop post-cardiotomy shock. The other way is an escalation of support with people who have an acute MI. They get a CP Impella, and they have the LAD open, and they go up to Uli's unit, and all of a sudden they start decompensating. They're getting worse. That's another way in which this device is used. The way that is, and it's approved for all these users. These are all shock entities. What is not approved as, in any of those situations, the patient is bridged either to recovery, hopefully, to HeartMate 3, durable LVAD, to transplant, or to palliative care. Now, what has not been evaluated or approved for is a preemptive use in high-risk surgery. And that's what we're sort of talking about here, right? To avoid post-cardiotomy shock. So it has been used off-label with this indication, and NY uses the first time it was used, not this device, but the 5.0, which is a predecessor. And you see here there were 13 patients, 10-headed place right into the aorta, through to the axilla. These are sick patients. The ejection fraction is 19.6%. And extubation happened pretty quickly within 48 hours. There were no deaths. There was one stroke. So good data. Another paper showing this, 10 patients in a European center, and they had a mean ejection fraction of 21%, sick people. Survival 30 days was 100%, and the ejection fraction improved to 33%. Again, these are small anecdotal cases, case series suggesting that this is a feasible approach. There's no randomized clinical data for this. There's no evidence-based guidance to say, much like minimally invasive surgery, that this is the way to go. This is the biggest study. It's out of WashU, and 34 people who HRSCS means high-risk cardiac surgery. 21 of those were CABGs. And as you see here, survival to discharge was 91%, survival of 6 months was a little less, but the follow-up wasn't complete. And most of those people were in class 1 or class 2 heart failure. The trial is going to answer this question, or at least give us a better sense of how to use this device, is the IMPACT trial. And Ed Soltis and I are the national PIs for this trial. And basically, the trial involves 100 patients at 15 centers in the United States. The primary safety endpoint is a combination of all-cause mortality, stroke, or needing dialysis. The effective as endpoint is what we're talking about here, our ability to prevent post-cardiotomy shock. And how do we define post-cardiotomy shock? You think, well, it's easy to do that if you don't have a device, but how do you define post-cardiotomy shock if you have an Impella? Well, it means you need an RVAD in addition to Impella, or you need ECMO, or you need transplant, or you need a durable LVAD. That anytime. Or after you leave the ICU, if you have to go back to the ICU because you're in a low cardiac output state and you need any MCS. So one is a definition of escalation MCS, one is a post-ICU cardiac failure. Now, what are the factors favoring 5.5 support? Ejection fraction 15%. These are very sick people generally with big left ventricles, more than 6 centimeters. Whether they have viability or not, it's a subject of another study, but in general, more and more people are not thinking that's a very important variable. Greater than 6 centimeters. If you have any degree of mitral regurgitation, that off-pump procedure that the R was showing you is much harder to do. If they have RV dysfunction, same thing. High risk scores in the STS, and that means any of these things. That also makes what VR is proposing quite hard. And if they have a shock state or low blood pressure or borderline high filling pressure, again, all of those favor using this technology. If you have peripheral vascular disease as well, it's because you don't have the aortic balloon pump as an outlet should things go bad. So Uli must have read much to see the future, because on Monday I did this case, a 6-year-old man, hypertensive, diabetic, he's HIV, he's active smoker, he's had angioplasty, both lower extremities. He has ejection fractures qualified as severe systolic dysfunction. He presented with exertional angina, had a high calcium score on a CT, and then they, in an echo, he had what we call, he had a 30%, I'll qualify that, and a big ventricle, 6.6 centimeters. He had a left heart catheter. You can see the right coronary is occluded, the fills barely, right to right collaterals, and you have a very tight osteal LAD on the middle screen, and you see a very tight big OM. This is what I'm not sure many of you call this 30%. So that's his echo. And in fact, when we put him asleep in the operating room, his ejection fraction was calculated at 13%. 30% at the base only. At the base only, yeah. So you have a 13 moderate MR. In these cases, I like to put a femoral line in just in case I need a balloon pump. And we put the epicardial probe, and they were both calcified femorals. I couldn't do that. So what we did is we went on bypass. We sutured 10-millimeter graft to the ascending aorta and left it there, clamped it, did the operation with a CABG 2 on pump via sternotomy, maximally invasive. And then I couldn't come off bypass. He became hypotensive despite being on dobutamine, levofed, vasopressin. So without having to get everybody out of the room, put the lead on, bring the fluoro machine, wait for half an hour for all that, we just advanced this through the graft. It took less than 5 minutes to put it in. He was extubated in post-op hour 4. He was weaned off pressors that same day. At P2, he had excellent hemodynamics the next day, and he was unexpected uneventful yesterday, and so far is doing quite well. So why you failed 5.5 in this particular case? this is not an EF of 40%. This is a patient who's got a big heart, I would assume. And the best option in a non-emergent setting is a full LV unloading device. It'll allow you to recover this ventricle, allow it to rest from the trauma. Even your operation causes trauma. Given the pressure volume loops that all these devices have, without a doubt, Impel Fiber 5 is the best unloading device we have. And what if things don't go well? Well, I have a device in place that will allow me to extubate, ambulate the patient, and then get Cecilia and Christiana to launch an LVAD or transplant evaluation and figure out what we're going to do with them. The limitations are few, but the device is very expensive, but in general has a favorable benefit risk profile. Thank you very much.
Thank you both of you for a great debate, which I don't think we're going to come up with an answer here, but it just illustrates how sophisticated surgery is actually. No, it was really so yeah, why don't you comment on this case that you just showed? Would you have approached this on different basis or? Thanks, Lee. Well, to be honest, that patient was in shock because it's been to the operation, right? If that patient had been operated in my center, we would have taken information.
No, he'd be home by now.
I'm not sure we'd be home by now, but I wouldn't surprise me at all if that kind of patient that could have it visa and that will not be well after. But again, it's don't you did a great job taking out of the OR and you say that extra procedure, but they can do not every patient can start doing after if they get an antenna, not to remind them. So because not everyone does that well, and any kind of support, this is procedure, it's additional place. But again, I wouldn't have done anything differently except for doing this kind of anything, and I wouldn't have done with anything. And if I would go stand and I would do CBT, I was going to eat. That's the way we do it. If you have a patient in myocardial infarction, into the operating room, into the part, and you have a sleep the heart. I don't really want CBT. We stand out and make sure that the patient has enough cardiac operation, then we can have to do the bypass. And that makes a lot of sense. If you really stop in part of you really need to kind of do that for how it is infarcting right now. That patient should go better afterwards. That's the idea.
And we don't operate with patients anymore, thanks to a professional cardiologist. So PMI is not an operation including more thankful anyway. And I completely agree with you. Can you tell me, you guys do, there's a hybrid of what we both presented. You can do minimally invasive with Impel support. Do you have any experience with that, or do you know what the literature shows?
I'm not aware of anyone doing this, to be honest, and I never do that by myself. I've done 5 or 6 patient packages with Impel that I stopped doing because like 50% of them went back to the office or the complications. And the problem was at that time, the company was like kind of insisting on keeping the patient different. But then it changed that to bicarbonate. Yeah. Simply use bicarbonate and the patient, because there is nothing worse than, as I said, that some of the operating room and you have to make sure that patient is having a complete normal ACT value. So you get careful in the operating patient. But thinking that in LA, the patient needs to lean and I remember one patient that I never forget, went back to the operating room twice in the same night. It was a stable patient. I just tried to do this, like, that was my time last 5 years ago. Stable patient, I put him on an antenna to do this, because it sounds like a train, like people are doing this with a patient with bad ejection fraction. I put that patient on an antenna, I would count, like any other patient, and then one time went through our 4 times, and at the end, after we switched heparin, completely, because the company was trying to do that. After starting heparin, it doesn't stop bleeding. So since then, I don't do it. But again, another minimum basic was It's very quick answer. Right have passed before the procedure optimizing, does that play a role in the administrative strategy?
You do it. Not really, no, because an interpretation is, application, they should be incentive on week for that, and probably not operating hope, so that again, if answer, operating.
Again, as you think of the vision of our new shot is about impelled trial, impact trial does not require you to write about to be encouraging it. I think it helps us in the decision making as further factors for this procedure.
I travel a lot between New York and
I travel a lot between New York and Düsseldorf. We are very different here. And when it comes to you, I will tell you, do what you want to do. And I'm going to tell the same to you, and I hope that that's very confident you can. So we're ready for the next break, and then in about 25 minutes, I believe that Steve is going to give a state-of-the-art talk on structural internet. So thank you both of you.
It's 13. Sounds intelligent. It's a developer just over the hairs. But it's not the native. Excellent. So these are the bikes all you want to send to people. These are all I'm doing.
Based on you.
I mean, already Friday, Saturday, you come on Saturday.
Oh, yeah. Strong supporter always. Always.
Let's see what they're saying here. That's the main, right?
This one.
This is the main? No, we're doing it from here.
No, we don't, we can't. we
No,
can't
this
watch
is the
such-
videos here. This is only for,
This is the one. When you move it, look up there. When
no,
you,
I get it, I get it, I get it. Yeah, I get it. No, but over here. but
you
one
have
of
to start sharing.
Right. Where is, yeah, watch. Look what I did over here. Bring this down. Where's the guy? Oh. Okay, here. Here,
Where's the mouse at?
over here.
The keyboard.
See, he's the one
Yeah, when you
that
stop sharing,
shows the,
yeah. Now you can go.
yeah, but I will have to go to my email. I'm not connected here. I will have to go in there.
How much time do I have? What state of the arts? What keynote?
What did I put? What did I put? Let's see. 30 minutes. Okay, but then we do the cases. Okay, so if you don't need that, that's great, and then we can have a little more interactive. Okay.
What state of the arts? What keynote? What did I put? What did I put? Let's see.
Who's talking? I'm going to introduce you.
Okay.
30 minutes. Okay. But then we do the cases.
We're hearing you. There's a delay.
Oh, yeah, it's a delay. Just turn that off. Yeah.
It's still. Let's turn that off.
Yeah, it's delayed. No, I said that 2 minutes ago. It's a delay.
She has recorded. Now it's.
You know, it's because Millie just said everything went without a glitch today. That's why that happened.
There we go.
You jinxed it.
It's too late. No, I said it 2 minutes ago. It's delayed. Because Jim just said everything went without a glitch.
They should.
That's why that
They
happened.
should stop that.
Who's running that?
Papi, go to the.
This is on, yes. Okay, great. So welcome again. We're in for a very special treat. Azim Latif is the one of the course directors for the New York Valves meeting, and probably has since yesterday already given 7 lectures and shown 3 first in man that he did in another country. And his side job is to be chief of interventional cardiology for the whole system here with us. And for those who don't know him, I think everybody knows him, but Azim joined us 5 years ago and has, I think, absolutely revolutionized what we can do here at Montefiore. And it was really a gift to the heart failure group and to our surgeons, I think. So very happy to you make time for us today and give us an overview of the state of the art of percutaneous mitral and aortic valve therapy. Thanks, Azim.
Thanks, Uli, for that kind introduction. I really feel every day I come to work at Monty, I feel honored and privileged to work with the people I work with. So thank you to all of you. We good? Okay. So I'm going to be covering quite a large subject, aortic and mitral valve therapy and transcatheter therapy. So let's start with aortic because I think that's a little bit more straightforward and a lot more established. And then we'll go on to mitral. I guess this mouse doesn't work. Let's try that. I do have some conflicts of interest related to consulting for companies that develop mitral and aortic valves. So right now, TAVR is the default therapy for aortic stenosis, and that just didn't happen overnight. Right? Alain Cribier, who did the first transcatheter aortic valve in 2002, just died this year. And with his death, a lot of us have had time to reflect on how this field has developed and changed. And one of the things I can say confidently that TAVR didn't develop just because companies wanted to make money, just because it was a cool device. It actually developed on the basis of well-run, randomized clinical control trials. And what we did was we studied this technology in a very stepwise fashion, completely different to what happened with stents. When stents were developed, they did it in the young patients who could go to open heart surgery. When we started TAVR, we went for the worst patients. We took the patients that no one wanted, that were going to die. 50% died within 6 months if they didn't get any therapy, and we studied those. And so we started with, as you see on top, inoperable patients, and we showed in those patients, we make patients live longer, and it was superior to doing nothing. We then went to patients who were high risk for cardiac surgery, and again, we showed that TAVR was non-inferior, and in some cases superior to surgical aortic valve replacement. You then went to intermediate risk and then to low risk patients. And in every group, TAVR has been shown to be non-inferior to surgical aortic valve replacement. But from the patient perspective, what's important? They don't care about data. They don't care about how many randomized studies have been done. Patients care about not dying. They don't want to have a stroke. They don't want to be in hospital again. And they care about the kind of complications that can happen afterwards. So if you look at all the studies and you put them together in a meta-analysis, really what it shows is that TAVR has great reduction in mortality compared to surgical aortic valve replacement, 12% relative risk reduction up to 2 years. When you look at and also it's important how you get the valve there. That mortality benefits only if you can deliver the valve transfemorally. If you deliver it via a non-transfemoral route, which we no longer do really at Monte, and just about everything's transfemoral, you lose that benefit. They care about stroke, and there are different mechanisms and causes for stroke depending on whether you're undergoing a transcatheter valve replacement or a surgical valve replacement, and the timing of that stroke also differs. And when you look at stroke, again, you see really not a big difference. You look at any stroke, there's a 90% risk reduction. When you look at disabling stroke, it really, I'll use the terminology, the incorrect terminology of Danny earlier, to say that it's going towards TAVR. But actually, there's really no difference, because once it crosses the unity line, it's really insignificant. Rehospitalization, again, a significant improvement in rehospitalization. And then when you look at other events, acute kidney injury, decrease, new onset AFib, decrease, major bleeding, decrease. However, there are also downsides of TAVR. There's the fact that there's more pacemakers with TAVR compared to surgical aortic valve replacement, and paravalvular leak is slightly more compared to, although with the newer technologies we're using, even that has changed. As a result of all these clinical studies, TAVR now has a class 1 indication. And it's a little different in Europe versus the US. In the US, it's really independent of surgical risk, and anybody over 65 and older should be assessed by a heart team. And if that heart team feels that it's suitable, TAVR has a similar class 1 indication to surgery. In patients over 80, actually it has a stronger indication according to the ACC guidelines. So the biggest study really to have impact on TAVR volumes in the last few years, but also create the most challenges, has been the low-risk studies. So these were patients who were low surgical risk. It didn't mean they were 50 years old. I want to highlight that. Low surgical risk in these studies were patients in their 70s and late 70s. They weren't 50-year-olds, they weren't 40-year-olds, they were elderly patients. And since that study came out, you see how really the kind of patients that are being treated with TAVR in the United States has changed. So this blue line here at the bottom is low risk. And up until sort of 2018, 2019, we stayed away from those patients. When the low risk data became available, you see now how it's almost 1/3, 1/3, 1/3 between inoperable or extreme risk, high risk, intermediate risk, and low risk. And what's that resulted in is this really explosion of TAVR in the United States. Currently, 73% of all AVRs are being done by TAVR. That number will probably go up to 85% within the next 2 to 3 years. If you look at already in 2018, the number of TAVRs outnumbered the number of surgical aortic valve replacements significantly, and that will continue. Why will it continue? Well, patients are living longer in the United States in particular. So if you look at what will happen between sort of 2020 and 2030, the number of patients will be 80 and above will increase by 44%, and then over the following 30 years by 149%. So as our population gets older and there are more patients over 80, there'll be more aortic stenosis because valves will run, the patient's native valve will no longer last as long as they have in the past. Another concept that's probably going to change starting this year is the whole concept of upstream TAVR. So for most of you who see a patient with aortic stenosis and refer them for surgery, you wait till the patient's symptomatic. They've had symptoms, S is severe, right? The gradient's above 40 or the valve area is below 1. So there are a whole lot of studies now looking at what's called upstream TAVR. So why are we waiting till patients have had permanent cardiac damage? Can we intervene before? The first data will come out of TCT this year called the early TAVR study, where asymptomatic patients have been randomized to TAVR versus medical therapy. There's already some data showing for surgical AVR that it's beneficial, that you shouldn't wait for symptoms. So we'll hopefully have that data for TAVR as well. But probably what will result in a huge increase, if the study is positive, are the 2 studies looking at moderate AS. So there are 2 studies, one that's completely enrolled called Progress, in which patients with now moderate aortic stenosis, so the gradient no longer has to be above 40, can be 20 to 40, and either symptoms or high BNP or some evidence of cardiac damage were randomized to TAVR versus medical therapy. And that could result in a large increase in the number of patients. But I do want to be careful. I do think we have to be careful not to say TAVR is for everybody. This is one slide that worries me a little bit and concerns me. I love TAVR. I love offering my patients TAVR, but I don't offer it to every patient. There are a lot of patients who do better with surgical aortic valve replacement. And the reason this study concerns me a little bit is when you look at the patients under 65, how rapidly TAVR is increasing in those patients. Those are the patients we tend not to do in our center with TAVR. They go to Danny and his team and they get a surgical aortic valve replacement. But if you look at what's happening in the United States, it is concerning how the number of patients under 65 getting a TAVR is increasing. With valves, which I will honestly say, we don't know 15-year data as far as durability. So we have to be careful of this growing sort of trend. TAVR, it shouldn't be for everybody. It should be for the appropriate patients that have been studied in well-conducted randomized trials where we have clinical data. One of the other concepts, and I feel sad that we only as cardiologists, interventional cardiologists, learned it so late because surgeons, I think, this concept is something that's apparent for cardiac surgeons in everything they do, is the whole concept of lifetime management. So when we were doing patients who were 90 years old, I didn't really care what was going to happen when that valve degenerated, because generally the valve lasted longer than the patient. But now when I'm treating somebody who's 65, who has a life expectancy of 20 to 30 years, it becomes much more important thinking about what the first valve will be. Will that first valve be a TAVR valve? What will we do afterwards if the patient has coronary disease? Is it okay to have high pacemaker rates in patients who are younger? Is it okay to accept PVL in a patient who's 65 years and has 20 years ahead of them? And what about valve durability? And so this whole concept of what is the best first valve and how you'll sequence what will happen to them in their lifespan has become really important. And depending on their age, how are we going to start? Are we going to start with a TAVR valve? Then when that degenerates, explant it, give that patient a surgical valve and then do valve in valve. Of course, if they're young, they're going to get a mechanical valve, but we're sitting sort of very much now with a lot of patients that are in that range where they are going to need more than one valve in their lifetime, maybe 2, maybe 3 valves in their lifetime, because let's face it, valves don't last forever. Yeah, we haven't found that valve. And so when we think about lifetime management, this whole concept of thinking about what's the best first valve for a patient becomes extremely important. So the companies are responding with technology. They're already responding by changing the current technologies we're using. So the Medtronic valve now has these big open cells to allow future coronary access. Edwards, which is the biggest producer of surgical and transcatheter valves, have changed their tissue to the Resilia tissue and are now looking at even other valves that will allow for us to rotate the valve, have commissural alignment, and maintain coronary access in the future. I thought we also talking about innovation. I thought I'd show you this valve. This is a valve that we led here as Monte. We did the first implant in the United States. This is called the DuraVar valve. So here, this company called Antares that's been doing tissue for 15 years have tried a new way of developing aortic valves. So if you remember, all aortic valves are 3 leaflets that are sewed onto a prosthesis. They took a single leaflet and tried to recreate what a human aortic valve would look like, and they 3D shaped it. And they put it on a balloon expandable technology, which is the easiest to implant with commissural alignment. I think these are pictures from one of the first cases we did here at Monte. And what was incredible about the technology, we only treated patients with really small annuli. So these are patients that would get like a 23 millimeter valve. I think what is fascinating is when you look at that echo picture, for those of you who look at the leaflets, you notice that large sort of coaptation zone that someone yesterday told me looks like someone praying, hands praying. That is very unusual when you see that, because with other valves, even surgical valves, we don't see this large coaptation zone. And what it's resulted in is hemodynamics that I have not seen yet in small annuli. So here, for me to see an EOA of 2.2 in a small annulus with a 23 millimeter valve, or single digit gradients, or DVIs that are 0.64 is very unusual with surgical and transcatheter valves. And I think even more interesting is some of the MRI data that we're seeing. So we're doing a sub-study in this where we're looking at flow and what flow, if we can restore laminar flow. So I'm not a CMR expert, and hopefully Aldo or no one else here is in the room to tell me I'm talking complete crap, but I'm going to just tell you in colors, right? So here's the healthy aortic valve. Notice how all that red is very uniform and circular in the aortic valve, right? If you look at someone with severe aortic stenosis here in the bottom, you see how it's more now like slit-like coming through that orifice. And when you look at the typical valves, even surgical valves we never see that full circular red during CMR flow. And look at this valve. It looks very similar to what a normal valve is. So maybe we can recreate what laminar flow and what the native valve looks like. And we think these kind of advances and these kind of technologies will result maybe in having valves that will last longer. So we're no longer talking just about, oh, what will we do in 10 years or 15 years when the surgical valve degenerates or the TAVR valve degenerates, but maybe you can give a patient one valve that will last their lifetime. And I think that's very exciting. And there continues to be innovation. I just wanted to drop some little things of innovation that are happening in the TAVR field, because it's such an established field, but we've even discovered that there are new metals we can use for the stent. So here's a company that just started their first in human that have discovered there's a new metal they can use for the stent that's 8 times stronger than the current metals we use. So it can really push a calcified valve away, but they can now shrink this valve to maybe being 8 French instead of 14. That becomes like doing a PCI procedure on a patient as far as excess size goes. So we'll take a little switch to mitral and tell you, I think, some of the innovation we're seeing in mitral. One of the things I've had to learn, and I feel like every day I do a mitral case, I'm still learning, is how complex the mitral valve is, how diverse it is, and how many different diseases there are. And I think this is one of the areas where I count myself lucky. I got to work with Professor Alfieri for 12 years. And I probably learned most of what I know about mitral valves from him, because he was very open to taking me to the OR, showing me what he was doing to mitral valves and how I could learn from that to develop devices. So the landscape for mitral is very exciting. These are all the companies. Danny, It's a lot of companies here, man. There's so much development in mitral, so much money being thrown into it because it's seen as an area of huge growth, because the number of patients with mitral disease are actually much more common than the patients who have aortic valve disease. But I want to take a step back to say, because as I show you new technologies, I don't want you to think that we're now just treating everybody with mitral disease. We really do follow the guidelines. So when we think about mitral disease for primary MR, we follow what our guidelines say is we try only to treat degenerative MR in patients who are considered high surgical risk or prohibitive surgical risk. When it comes to functional MR, thanks to the COAP study, we will treat patients irrespective of age or surgical risk if they have a low ejection fraction, because transcatheter edge-to-edge repair has a class 2A indication, which is higher than the indication for mitral valve surgery. But once again, with transcatheter therapies, it's hard to stop them. I wanted to show the guidelines because then I do think we need to stick to the guidelines and need to build data, but then you see the numbers that are happening, and one does get concerned that the numbers don't really reflect what the guidelines are. So this is really looking at the number of cases and sites that are now doing transcatheter mitral procedures in the United States. Between 2014 and 2021, it increased from 99 centers to 507, and the number of cases annually has increased dramatically. Probably be next year around about 30,000 edge-to-edge repairs being done with the transcatheter technique in the United States. Around about 2019, TEER also became the predominant way of treating a mitral valve and outnumbers the number of surgical procedures. But look at the age. So some people think that these numbers come because I'm treating 50-year-old patients, they should undergo surgery. That's not true. If you look at the average age of patients we're treating, they're still elderly patients, most of them octogenarians. And if you look at the data, this is the STS data for the whole United States. In Q1 of 2022, the average age of a patient getting a transcatheter procedure is 79 years. Not 59 years, not 69 years, 79 years. So with all this data, it's probably increased in 10 years, the average age from 82 to 79. We're still treating elderly patients who are high risk. And how are we doing that? These are the two devices that we have approved in the United States that really redo what was the Alfieri technique, or what is the Alfieri technique of edge-to-edge repair. So bringing two leaflets together, the anterior and the posterior, and trying to reduce mitral regurgitation. We can do this for both functional as well as degenerative mitral regurgitation, and we have a number of different devices we can use. We've also become much better in trying to understand which are the easy cases, which are the cases that will not do well with these procedures. And there's been a number of published guidelines suggesting, this is an easy case anatomically for a TEER procedure. This is a case where maybe you should go to an expert center because the anatomy is much more complex. Or maybe this is a case where TEER is not going to work because there's so much calcification of the annulus or the valve that you're not going to get a great result. So what do we do in those patients? We'll look at that in a moment. But this is the typical kind of patient the heart failure team sends me. 80-year-old patient, non-ischemic dilated cardiomyopathy, who's on GDMT. I should probably increase, I like my rule about GDMTs, I always look is, are they on Entresto? And that's why I had Entresto. Now I have to look, are they on Entresto and an SGLT2 inhibitor? That's all that Uli taught me, is make sure they're on those two before you clip them. So I always check. If they're not on the SGLT2 inhibitor, I send them back to Uli and the team and say, please put them on an SGLT2 inhibitor, which I hate, by the way, because it's putting me out of business. But those drugs do make a difference. So this is a typical functional MR patient that we'll treat, 80 years old, ejection fraction 40%, severe MR by all criteria. Here you see the hemodynamic showing large V waves. And this is the sort of typical case we'll do. We'll try and go in the center, put a device in A2P2, and hopefully get results like this, where the patient V waves come down. You now don't see CV waves, you see A and V waves, and the patient's MR is all but reduced or disappeared. So in highly selected patients, this is what we can do. And the fact that it's on a beating heart allows you to make a judgment on whether you put another device, or at times we'll pull out. We'll say we're not going to get a good result with this device and we'll take it out. The data to support it really for functional MR is COAPT, which has shown a reduction for the first time ever with a device for reducing MR, a reduction in mortality, heart failure hospitalization, and really every single endpoint they looked at in patients who are on good medical therapy. If you add a clip for their severe MR, you can decrease their mortality and decrease their heart failure hospitalization. We'll also treat some more complex cases. Usually this is the case where I think Danny's texting me and going, don't do something stupid, Azim. This patient is probably going to die in the cath lab if you try and do this, but I sometimes have to do stupid things, so I will. So this is a 65-year-old patient with multivessel disease who had a PCI complicated by vessel closure and cardiogenic shock, was on inotropes with an impeller and was impossible to wean off the impeller, had severe MR. And so with the impeller, we took the patient back to the cath lab, put one clip in the center, and within 24 hours, the patient's off inotropes and impeller and goes home. But I told you, there's this whole sort of red zone of patients I can't treat with TIA. So we're always trying to find other ways of treating them with transcatheter devices. This is another way in patients with functional MR. Can we actually improve their posterior leaflet? Because often they have marked posterior leaflet tethering or short posterior leaflet. So this is the Half Moon device. I think we've done 4 cases now here at Monte. It's a device we place via transcatheter approach. We really replace the posterior leaflet and give the valve a coaptation zone to coapt against. And really, we've been using it in that red zone patients that are not good candidates for mitral clip. So here's the last case we did. I think this was in April this year. 82-year-old patient, NYHA class 3, 3+ MR at least. Patient has an ICD. I'm sorry, the video suddenly are not working anymore. The patient has an ICD, EF of 37%, high surgical risk with an STS of 13.8%. So in this patient, we put this device in. You can see the severe MR here. This is what the result looked like immediately. The procedure was 1.5 hours. The pulmonary pressures in the procedure went from a systolic of 59 to 37, and the means dropped from 28 to 21. The patient now at 1 month saw us in clinic and has almost normal pulmonary pressures and is feeling fantastic. So you're just showing the result. This patient had a baseline gradient, and despite that, the gradient didn't go up too much with this new device. So other things we're looking at to try and resolve and help mitral regurgitation and finding innovative ways are transeptal chordal therapies. So this is for the neocord procedure, the Nexus procedure, where you can percutaneously attach 2 cords to a prolapsed area, then attach those cords to an anchor that's attached to a pulmonary muscle and pull down the prolapse. So essentially do what a surgeon would do for prolapse, which is add artificial cords. I think this is a very exciting procedure because you're not putting a device across the valve, you're leaving the valve free and open, and is most similar to what a surgical procedure would be. So here's one of the patients we've treated with transeptal neocords, a large P2 prolapse in this patient. This is the pre. You can see the post here, how we've really pulled down that P2 prolapse, and there's really no MR, and this patient has no device across that valve. There's no edge-to-edge device. Here, just showing you stability in this patient. This was the CT CAT scan at 30 days. You see this anchor we've put into the pulmonary muscle that's pulling down the posterior leaflet, and you see how at 6 months and at 12 months, this patient's ejection fraction has improved. They still have trace MR, and the EF has improved. The last area, very briefly, where we're excited about, but has been challenging, is there's some patients where we can't repair their valves, and could we replace their valves? So we involved in three of these devices that you see on the screen here, and I'll just show you one of them. This is an 81-year-old patient who came to us. She had a CABG ×2 and a surgical mitral valve repair with commissuroplasties and edge-to-edge sutures. They were unable to replace the valve or put a ring because of extensive MAC. These are one of the hardest patients to treat because of severe MAC. The patient was sort of within 6 months to a year, again, had all the symptoms they had before surgery, with worsening shortness of breath on minimal exertion, normal EF. And here you see this valve with really severe MAC on the valve. This is really a valve that is very difficult to repair. The patient had a mean grade of 7, severe pulmonary hypertension with a systolic pressure of 73. When we did our echo, it looked like out of the 3 commissuroplasties, 2 had come out, but there was still 1 attached to the valve on the lateral aspect. So one of those sutures was still there, which kind of made it a little bit challenging to think how we would replace this valve. We clearly could not repair this valve. I would never try and clip this valve because the patient would end up with mitral stenosis. So here, just showing you again the history of this patient. This was in 2022, before surgical mitral valve repair. Had a really good result with surgical mitral valve repair, but because her tissue was just so fragile, it had so much calcium and was so degenerated, within a year, had again severe MR. And here you just see the severity of the MAC. I mean, here you can't put sutures in to try, and you can try and decalcify this, I guess, but the risk of that in such an elderly patient are very high. So I think, obviously the surgical repair was appropriate. The question was, what do we do now, particularly with a edge-to-edge that's still there? So we enrolled the patient in the SOPHIA trial, which is evaluating this new transcatheter transeptal mitral valve, which is 32 French, fully repositionable and recapturable. But we had a challenge because there was still the surgical suture left behind. So we now can do electrosurgery via catheters. So we went in with catheters and we burnt away the suture, freeing up the suture. And this is what it is showing here. Here the catheter is going around that surgical suture, which we'll then cut percutaneously. We've now cut it, so there's no suture, nothing blocking our way, and we can now put in a valve. Here's the SOPHIA valve, 36 millimeter valve being implanted. We start ventricular, pull the valve up towards the annulus, and then release the valve. And you see there how well it's anchored on the MAC. You can use this valve even without any MAC in functional MR with no calcium too. And you see how the dramatic improvement in this patient. The immediate post-procedure, the systolic PA pressure went from 84 to 53, the mean pressure from 50 to 34, and the wedge pressure went down. This is what it looked like pre, and again, this is 4 months post. You see patients going back to gym, has no limitations, and we really abolished the MR. So I'm going to stop there. I think TAVR has become the predominant therapy for aortic stenosis. Patients want minimally invasive therapy, especially if they're elderly. Upstream TAVR will be the next frontier and will further increase the number of patients requiring treatment. There are a lot of new valves that are being designed specifically for younger patients that will hopefully last these patients their lifetime. When it comes to mitral, it remains very challenging. I think in the transcatheter world, we will end up with a toolbox of multiple devices. TIA is still the safest and most effective, but we do have some newer technologies that will offer unique opportunities to treat complex patients. And I think when we think about these patients' lifetime management and not thinking about just a single procedure, but thinking about procedures down the road will become increasingly important. Thank you for your attention.
That was perfect. Then we go to VR. Edwin will present, when you come to the panel. Edwin will present with clinical, with two surgeons, with interventionalists. And really, it was actually first, I usually, the surgeon was comparing that they were trying to set it up and you have to set. But the few times we chased about So Edwin and Andrea we have 3 cases, I think, right? Yeah. And I think the idea here is people. One is to showcase that fortunately we do another center where the interventionalists and the surgeons fight over the cases, and surgical center or interventional, but rather we are a valve center. The idea is that we can serve anybody for anything as a team. So we have a few cases that they show new stuff, and we are in front here on the TV to illustrate some concepts. And if you're in the audience and something is unclear, don't be shy. Next 2 cases are really to show what's new, what's going on, and for us to understand the concept really. So take a look.
Perfect.
So we have three cases, an aortic, a mitral, and a tricuspid case. We will follow this order, so we will start with the aortic case. And together with Edwino, we will present you all of them. We start with this case. This is a TAVR, but it's not a classic transfemoral TAVR, just to show you something different that we can offer here in Monte. This is a patient that you will see with very severe peripheral artery disease, so we had to explore an alternative access, and we did this transcaval TAVR. So we will see what transcaval means. This is a woman of 85 years. These are the comorbidities, usual comorbidities we see in patients with aortic stenosis. No cardiac history. Those were the medications basically for her hypertension and hyperlipidemia, diabetes. And she was admitted to the hospital with acute heart failure. So the first thing that was done was a transthoracic echocardiography. And here, as you can see, there was normal LV wall motion. The ejection fraction was preserved. And as you can see on the right, there was severe aortic stenosis. The mean gradient was almost 50 millimeters mercury with an aortic valve area of 0.8. So at this point, as in all the aortic stenosis patients, we did the CT. This is the CT that you can see here. What we do, just briefly, we measure the annulus. We look at the sinotubular junction. We look at the coronaries, if the height is enough, not to risk any coronary occlusion, the sinuses, and the calcification of the valve. So here, everything is looking promising. We can offer TAVR to this patient, but also we need to see if we can reach the aortic valve. So we need to see if the access is good. And in this case, of course, as we saw before, transfemoral has to be the first option for all our TAVR cases. In this case, unfortunately, transfemoral access was not possible in both right and left. As you can see, there were severe calcifications, many areas of focal dissections, heavy disease, and diameter of 3 on the right, and also on the left, 3 millimeters. So we couldn't go with a 14 French sheet clearly here from both legs. So we had to explore alternative accesses, and we look at the transaxillary access. Here, the caliber of the vessel was good, but as you can see here, there was too much tortuosity. This is a very fragile artery, so we couldn't risk rupturing the subclavian. So this was clearly not a feasible option. And so the other option was transcaval. Transcaval means that we access the vein rather than the artery. We go up to the IVC, and then we basically go to the aorta, doing this perforation that you can see here with, let me use the mouse, okay, with the catheter. So we go from the vein, then we use a wire just to connect the IVC and the aorta, and then we can do our TAVR procedure, bringing the sheet to be from the IVC to the aorta. So what we look at the CT here is clearly we need to find a good spot where to go from the IVC to the aorta. We want to stay below the renal arteries and also above the iliac bifurcation. In this case, there was a very good area, like there were 6 centimeters, 60 millimeters between the renal arteries and the bifurcation. And here, as you can see, there was a very good area between L2 and L3 where we can go from the IVC to the aorta. This is important also because this will be our reference when we are doing TAVR under using fluoro. So here I will show you, this is from the vein, the IVC. This is from the artery. So we access the artery, but this is a very small catheter. So even the 3 millimeters were enough for a pigtail. We see here, we identify using the vertebra, like the ideal point to puncture. This is our catheter. We look into projections. This one, which is an anteroposterior view, and this one that is an anterolateral view. This one is a snare. Basically, this is used, and I will show you after we perforate to capture the wire and then bring the wire up into the descending aorta. So these were the access sites that we used. A 14 French right femoral vein and not artery. That was our main TAVR access. A 6 French right femoral artery and a 6 French right radial artery for cerebral protection. So this is how the procedure is performed. We perform this electrosurgical burn. Then we use this snare to bring the wire up into the descending aorta. And then we bring all the delivery system. In this case was a little bit challenging, so we had to dilate with the coronary balloon, and then we could advance the sheet, as you can see here with the on the right of the screen. So after we place the sheet here, we can advance the TAVR. It's as easy as any classic transfemoral TAVR. This is the valve that is released as in any transfemoral case. And so the procedure is done. But at this point, we have a 14 French hole in the aorta and in the IVC. So the question is, what do we do? Like, do we remove the sheet? Will the patient exsanguinate? And this is the beauty about this access. And this is why this transcaval TAVR works. So when we remove the sheet, we have to consider that we have a very high pressure in the aorta, a negative pressure in the IVC, but there is also positive pressure in the retroperitoneal space. And since the flow goes from high to low pressure, there is basically no flow going into the retroperitoneal space. And this is clearly demonstrated, thanks to Toby Rogers, who shared these slides with us, how the blood is going from the aorta to the IVC. So, and this is, of course, we are not keeping the hole open. We will close this hole and I will show you how, but this is just to show you that we are not risking any hemodynamic collapse in these patients because we are not losing all this blood in the retroperitoneal space. And this is also a nice figure that is showing you why the blood flow is going from the aorta again to the IVC. The closure is done with this device that is placed on the aortic side. This is an angiography just to confirm that the position is good. And then this is the final check that we do just to confirm that we have adequate sealing. And so we can conclude the procedure and bring the patient out of the operating room. This is a 1-month follow-up, normal valve function, no vascular complications, and the patient was doing fine with no symptoms and as every other TAVR. Thank you.
I think the first time you found was 2 years ago, or? Yeah, probably a little bit longer. It was probably done about 5 years ago already. It was invented by the NIH, and we did the NIH. We invented this whole area of the network surgery. So it started with transcaval. Now we will do other things. I mean, I showed you the one where we can cut away sutures from the HPA. We've also cut leaflets in half. Aortic leaflets to prevent coronary obstruction. And then the other thing we've done is what's called an pooling, where if there's a risk of when we do a valve innovation, but the extra leaflet will close the alveolar, we'll slip the leaflet first percutaneously and then put a valve. So there's a whole area of can you do surgical like procedure by cutting the catheters and wires inside the heart? And this is one of those procedures.
Show hands who have to settle themselves.
Only if my it's not true. When I was 85. If you were 85, you had no accents. If you don't, many times I really, I would should say, please do the other thing. And you have this one back,
Okay, great. Let's do the next case. There's one case actually where we need serious input because it's one of my patients.
We do this first.
Yeah. No. There was number of feelings here. I think you have to be careful. Honestly, with the microphone.
I think you have to be careful because the biggest complication is related to really the closure, right? So if you don't find a nice area to cross, okay, and when you cross, you can tear it away. And then the flat lead won't close. So when we do this procedure, we very carefully always make sure that specifically knows we have grafts, aortic grafts, and the graft available in the room.
So if I really can't close it, so what I'll try to do, is I'll just put kind of sit and I say. The area we're doing, so there is stents from trivascular that will really, very low profile, will really from family, and then like 12 to 14 frames OD, so you can get that upper band access. So what we'll do, we'll do the flat, we'll give protein before we do the flat, if that doesn't work, we'll play the green, and we're trying to close it, if that doesn't work, we'll put a covered stent. We haven't actually had to put a lot of covered stents because it's amazing how the physiology works, right? As long as there's still some check towards the IVC, it will be probably going to the IVC. But only if you block the IVC, then you have the retrograde.
Okay, great. Okay, we go to the next case. This is a mitral case. We will hopefully have a nice discussion on whether to repair or replace this valve. This is a gentleman of 78-year-old. He had anemia due to GI bleeding. There was this thymoma in the history, but what is important is the cardiac history. So he underwent in the 2004 CABG and bioprosthetic aortic valve replacement. After 7-8 months, he had endocarditis. So another procedure was required, the commando procedure, and the aortic valve was replaced with a mechanical valve. He also, from an EP standpoint, he was implanted with a CRTD. He underwent multiple ablations. And this is the list of all the medications he was on that you can see here on the right. So he presented to our structural clinic because he was very symptomatic for shortness of breath. He was in NOHA class 3. So the workup started with the transthoracic echocardiography. As you can read here, the LV was severely dilated. The ejection fraction was not bad, 52%, and there was severe mitral regurgitation. The mechanical aortic prosthesis was functioning well, mean gradient of 11. On the left heart catheterization, the grafts were patent, so no coronary artery disease to treat. And these are the numbers for the right heart cath. The pulmonary artery systolic pressure was 66 with a mean of 41, a wedge of 21 with a V of 41, and the cardiac index of around 2.5. So since I have Edwin here, maybe if for sure is the best to comment on the echo, so I will handle him.
Great, thanks, Andrea. And I think the other interesting thing about this patient clinically was that despite his symptoms, his cardiologist was actually at another center here in New York. And they were actually evaluated by a heart team there and was basically told there's nothing that can be done for you. And so the reason he ended up coming back to Monty is because Dr. DeRose did his original 2 surgeries. So he actually requested, let me get reevaluated at Montefiore. So it's kind of a nice story that he came back to us again to see if we could help him out. And then so what we're seeing on the left side images are the 3D TE pictures. And what we can appreciate along the back part of the mitral valve is that there's really this very thickened kind of bulbous region that doesn't have a lot of motion. And that's usually very highly suspicious for significant mitral annular calcification. You see there's a little tiny flail segment at P3. I'm just going to try to highlight here with my mouse. And then there's a really big eccentric jet of regurgitation coming from there, really heading laterally. And then the biplane images on the right again confirm that. And you can just appreciate how thickened and calcified the entire mitral valve complex really is. He already had a baseline transmitral gradient and then signs of severe mitral regurgitation even on the sort of hemodynamics that we can get on TEE. So then that takes us to our sort of heart team evaluation. So, you know, what are the options here? A second redo surgery? Do we think about edge-to-edge repair? Do we think about replacement? I don't know if our panel wants to comment at all. We have some surgeons and heart failure interventional. I think we do.
Yes, we have. But okay. We already showed you what we will do, but yes, this is the CT scan. No.
The mechanical AVR.
Yes, mechanical AVR. No, the aorta was not severely dilated.
Why do you ask?
I have no idea why you're asking, but I'm actually thinking of the same thing. Last time asked because if the patient having pulsing on the organ, it's simply to classify, so you don't have to think about it. We're looking for a way out. But if you wanna do a surgery on this patient, you have a more aorta, in this case, I doubt it, because he's having a low sensitivity. And the other thing is, we don't see the clinical condition, but he's in the use of those. So basically, it's a complete everything. So it's possible, maybe if we there, manuals was,
Can you make it clarify, because I'm not sure everybody knows what a commando is.
Sorry, so he's asking to clarify what's commando is. So actually, the patient was thinking what commando. The commando is that you basically, you do that to patient in the paralysis, you just not replace the aortic valve, you have to replace the aortic mitral curtain. Like the fibrous tissue, like combining the aortic with the mitral valve. It's a very demanding procedure. So in this patient, the anatomy is a little bit different than the video patient. That being said, pre-operative patient status with commando is not that easy than pre-operative patient like visually someone else to highlight.
Okay, so let me just take the obvious or the obvious question maybe. Why not just get it? No, I just want to bring that out.
Evan?
Yeah, so I mean, the main concerns here, very thickened calcified leaflets. There's not a lot of free margin or free leaflet that's really available to actually clip. Valve area is small. I don't think we have the MVA here, but it was, I think, under 3 actually. And there's already significant mitral stenosis based on the elevated gradient, although some of it is flow. But we know that will reduce usually the area of the valve by about half with one device in the middle. So it would cause severe stenosis for sure in someone like him.
So no surgery, no clip. So we're in the middle of the colorful thing in the beginning, right?
Correct. So that's why we opted for TMVR. This patient was screened for another device. We saw the Cephea valve before in the previous presentation. In this case, this is another valve that I will show you now. This is the CT analysis. We have the CT analysis here because this is not by default part of the workup if we are going for edge-to-edge repair. As you can see here, we measure the annulus of the mitral valve. Then we look at everything, the atrium, if it's big enough for our device to maneuver the catheters. We look at the LVOT, how big is the LVOT and the predicted new LVOT after we implant this new valve. Will this cause LVOT obstruction? In this case, it was almost 200, so it was not at high risk of LVOT obstruction. This is the valve that was used. It's Intrepid. It's as you can see, it's a very round circular valve with outer stent anchors without that is very conformable. Doesn't need to be oriented. There is this symmetrical design, and there is an inner stent which is a 27 millimeter valve with bovine pericardium valve leaflets. This valve now is available in 2 sizes, and another one is under development. So this is how the procedure is performed. So we're always going from the right femoral vein, IVC, right atrium, and then we have to perform a transeptal puncture. So we can go into the left atrium, and then we steer down, we maneuver all these catheters to reach the ventricle, and then we deploy this valve. And I will show you all the steps. This is the first step, transeptal access. The transeptal puncture was 4.5 centimeters, which corresponds to what Edwin predicted on his baseline T, but we know he's good in this. So this was exactly 4.5. We confirmed this in both view. What usually Edwin shows us is also this 3D view, which is very nice to see where our tenting is compared to the mitral valve, which is this structure here at the bottom of the 3D. So we have to dilate the interatrial septum in order to bring all our delivery system. We did this balloon valvuloplasty, and then once we are there, we use all the 3D guidance we can from echo to position and to move all the catheters and go into the left ventricle. In this case, we use also this fusion imaging, which is showing you where the left ventricle is also on fluoro and the left atrium. This is the mitral valve. Here we make sure that we are in line, that we are well oriented with the valve. And once we are satisfied, we move forward with the other steps of the procedure. The first step is releasing the atrial part of the valve. And then we basically push the valve to the mitral valve annulus. Here you can see on the right, especially on this 3D view, how nice we know that we are really opposed to the mitral valve, and then we release the valve. You can see the release on the left. So it's basically a 3-step procedure. And this is how the valve looks on fluoro in both long axis here with the delivery system and after the delivery system is removed with all the CRTD leads. This is the procedure. So before and after we closed, as I mentioned before, there was moderate to severe TR. So this is why we closed the ASD with this closure device, this Unplatzer device that you can see here on the right. And this is the result after having implanted this valve on the mitral valve position with trace MR, a mean gradient of 6, and no LVOT obstruction. So this is just to show you the baseline, again, that we saw before, post-TMVR, and the 1-month follow-up with maintained trace mitral regurgitation and the stable mean mitral valve gradient at 7 millimeters of mercury. Thank you.
Two questions. You need to go for a little bit. And well done. Thank you. That's great. One question. Sometimes when you have a severe math means severe match of complication match of what I a couple of times did is a power valve for the mitral. It's really nice. The problem with that is sometimes you may end up having your stress in your LVOT. But as do you have any measurement of the LVOT gradients after placement of the medical? Do you have any concerns that your LVOT gradient may be too significant?
So that's a great question. I think the biggest challenge for all these valves is your LVOT. That's the biggest reason we say that. The most important reason we find globalization in clinical study. So we spend a lot of time, when we do a data valve, is we will use the C2 and we'll put the side valve in and we'll calculate what the predicted in your LVOT is. And generally, we know about 140 millimeters squared a day, maybe even about 130. Here is 196. So we predicted we probably be okay. But we'll still measure the end. The problem with these valves, I mean, you saw your picture of the valve again.
Yes.
So the problem with this valve is it's all cut, all the struts are cut. So you can't modify the end to leave it more out. So when we do the side of the valve, we match, we'll modify the end to we'll cut the end even more. And slit it so that it opens up and those open struts, you can get blood flow through those struts. But with these kind of valves, definitely. And that's been a real challenge. Because usually, as you know, the valve and neck also have that strong dysfunction of small LVs that only have all the space. So this patient was lucky with straight, the long patient we say, oh, Jesus,
Right, and just to state the obvious again for those who are not fully into it, for the question. And so when you deploy the valve, you run a taste, I guess, or what do you do? That
For this one, yes.
Yes. So how long does it take to place as they're concerned or obstructing as you're placing it? How much time do you have to do the occupation going down?
Yeah, so usually what we do when we open that atrial brim, as long as we have enough height over the valve, that part is very stable because flow is going around the brim. But sometimes you never know. So if that ends up including flow, then we have to move very quickly. And then the actual deployment sequence involves rapid pacing because we stabilize the annulus. And then we actually watch it on echo as the brim comes down and just touches the annulus, then we deploy the rest of it. So it happens pretty quickly, like within 30 seconds.
You can see here on the image on the left, that's the time that is needed.
Yes. So that's the high stress period.
Great case. We had a similar case, and our interventionists were actually concerned about the obstruction of the upper tract for
suggesting to do alcoholization of the septum. Do you have any experience with that?
This is great suggestion. So we use alcohol sepultation in some cases. And the challenge is these patients don't have very good septum, right? This is not a open patient. They don't have 2 centimeters septum. Often their septum is like 14 millimeters only. So we'll try, if there's really a sigmoid septum, we'll try a local sepulation. It can work in some patients. You have to be very careful because if you give too much alcohol, you cause a VSD because they don't have a lot of septum. So we don't do it that often. We much rather prefer if we're doing a Tabo valve to slit the anterior leaflet and kind of open because that will give us the biggest space. And now there are also new procedures being developed by the NIH. There's a procedure called the septomy procedure, where they'll go into the sigmoid septum and they'll slice it percutaneously. And so this will just, because of the circular fibers, you look at it a month later and the whole septum is gone. It's like just thinned out. So we'll probably be starting a clinical study later this year, when we do our first septomy procedures, and we'll invite you down to the lab as we go do myectomies percutaneously.
They're like an open sesame kind of.
Exactly.
Yeah.
Very really good. Then the last patient is the patient we really need to figure out.
Calling the patient.
Yeah, exactly.
That's serious care.
I think we can start.
Okay, yeah, I think so too. I mean, he knows this patient, so he'll catch up very quickly. So I'll present this one. This is a patient that, you know, we share with Uli, and as you'll see, really involves the multidisciplinary heart team, because you sort of need a little bit of everyone in this one. So this is a gentleman, he's 73 years old. He has some past medical history, nothing is terrible. He has some degree of COPD, HFpEF, atrial fibrillation on a DOAC, anemia, thrombocytopenia, hyperlipidemia. He's had a previous pacemaker because of intermittent heart block. And then you can see his medical therapy there, titrated by Dr. Yorde, so excellent for HFpEF, of course. But he still has persistent and actually progressive symptoms. So from an NYHA point of view, probably about 2, but he does have some edema and abdominal fullness too. So he was sort of sent to us for review for his tricuspid regurgitation. On his TTE, I didn't show the full pictures. He has low normal LVEF, so it does count as HFpEF. The RV is dilated with mild systolic dysfunction, and he has, I call it 5+ TR because we use an expanded grading scheme for TR now. So they're severe, massive, torrential, and we know that does correlate with people's symptoms and their outcomes. The relevant labs, renal function is normal, but he does have, sorry, a slightly elevated bilirubin. And then these are his right heart catheterization numbers. So he has an elevated RAP with V wave, no significant pulmonary hypertension, and then the FIC cardiac index is less than 2. And then I just highlight the TRCW profile because it's very triangular, which for us tells us usually it's beyond that sort of just normal severe range. That's usually a sort of massive or torrential. He then had a TEE done. One of the things we know about the tricuspid nowadays is that not everyone has 3 leaflets. He has this interesting valve that doesn't really have an anterior posterior commissure. So he is probably one of these very unusual, almost 2 leaflet type morphologies. And then you can see where his pacemaker lead is. I marked it with the red arrow. It's sitting so slightly anterior to the central part. It doesn't look clearly impinged, but it's definitely sort of a little bit in the middle and like slightly in the way. We also do this sort of biplane imaging to try to understand sort of where things are at. And again, what we can really appreciate here and what we're trying to highlight is if you look at the pacemaker lead, it doesn't look like it has a lot of slack. It's sort of standing up very, very straight. The leaflets are tethered, meaning that the annular plane is where the leaflet hinges are. So like over here, and the leaflet tips are pulled downward. And then there's probably some septal leaflet interaction with the pacemaker because of, as you can see, probably this pacemaker lead is pushing against that septal leaflet. We oftentimes will get CT scans on tricuspid patients if they don't have significant renal dysfunction because it gives us so much extra anatomic information. There's so much variability on the right side of the heart. And that's especially true when someone has a pacemaker. And then what we can appreciate here is, again, that this pacemaker is crossing quite centrally and really doesn't have any slack. So you can see there's really not like a big bend in this pacemaker. And then the tip also, it looks like it's within the RV cavity. It doesn't look like it's through a papillary muscle, and it doesn't look like it's, gone through the RV free wall, which sometimes can occur. And that's just relevant because sometimes when we think about extraction, that can increase the risk of a complication. His annulus is very large. So you can see it's 180 millimeters to the perimeter. And then the derived diameter that we get is 56, which, as you'll see afterwards, can be an issue when we're trying to evaluate for devices. So we go through our usual evaluation. What are our options? Surgery? Do we think about transcatheter options like edge to edge? Do we think about replacement? I'll just quickly show you a few of the considerations, and then I think it'll be nice to have a little bit of discussion around this case. So if we think about surgery, we have two surgeons here, so I'll have them weigh in this. Again, earlier I mentioned we kind of use the TRI-score because there's not a lot of other risk scores that we can use. He technically meets criteria for 6 points. If you want to argue his right heart failure signs are not significant enough, then you could say maybe he's a 4 out of 12. So that risk prediction for mortality is somewhere between 8 and 22%, which seems quite high, at least from my point of view, and we'll get the surgery input in a moment. And then if we think about tri-clip, so some of the issues that come up with this, the gap is about 7 millimeters, which is borderline. We know when the gaps are greater than 7 millimeters, we're less likely to get a great result, and it can be a little bit more difficult. Same with significant tethering and a broad jet that goes commissure to commissure, which unfortunately he does have. And then the lead is a bit of a problem because it makes the visualization tough during a case. It makes the case tough because we have to work around this lead. And then we don't know about the long-term effects of device and lead interactions. And then lastly, well, what about replacement? And I gave you the talk earlier about the Evoke, which is now commercial. A problem with his annulus is it's just a little bit probably too big. It's right at 56 millimeter, which is the largest available Evoke, which is not actually technically commercial. It wasn't in the FDA submission, but we have access to it through continued access. And then there's concerns about stability, of course. And then the pacemaker lead can be an issue. Very little slack. Is it going to interact with the device? Is it going to flip the valve over by accident? So these are sort of all of our considerations. And then lastly, this lead extraction, I don't see Dr. DiBiase here anymore, which is unfortunate. So it may change his eligibility for therapies. Do we think it's going to change his TR? Probably not because of all that tethering. And then we don't risk jailing this lead permanently, but of course it's at the risk of an additional procedure. And then I think this is probably a good point to stop and have a little bit of discussion.
We just clarified the largest valve is 56. And he measures 54, but I guess he measures
57.
Yeah. So his the perimeter derived exactly.
Probably around 5 to 10%. Like 5 millimeters. Yeah. Okay.
I would be interested to know how the change of condition of patients is working along with somebody who's by having excited. Very good. Great, working along. My question from the right is wasn't that bad. He's having a severe TR, but I'm feeling the right is not doing well. It's mine. And we didn't have enough to put score of the right, but I saw it did not reach that back. So, but I would consider that the patient's working along and he's not having big anxieties, but something is concerning with the way we're doing measurables is now score. Yeah, yeah. But probably I would consider within the patient, putting some diuretics, see what the treatment confidence, the feedback, and probably GFR to the 30 without afraid of bacteria. I would not have that patient, but if not the case, I would put on diuretics and then prepare them for the patient with something that we really need to some mechanics of the base practice. I would go in and invade beating up tricuspid valve repair. What I mean with that is when we operate in there's a bunch of new publications with surgical tools showing up. We operate in the tricuspid valve beating up, which means the good efficient heart machine, the heart is beating all the time. When you operate in the patient, you don't treat hypothesia. That kind of patient will be much better afterwards. And if you good hypothesia, it's easier for a surgeon to have to stay when you do the procedure. Beating heart is kind of tricky, but it's has advantage for the patient. So that kind of patient, I would
this is 40 years old. And I can't do a perfect valve repair, and I can't, if I can see that it leads on my way, I probably able to reduce that achievements, and I will make perfect valve repair for that patient, but I think I would send something to the condition.
The practice maybe sort of challenging a little bit on that. And you also got severe academy, right? Okay, maybe you can clean up the leaflet, but I mean, with the lead there, putting a ring on a patient with severe cataract, I mean, that's a group of patients who don't do well. They don't have durable outcomes with repair.
Right, what I would do, I would just put a ring on it, I would flower technique. The flower technique, just for those who never heard about it, flower technique is just like you put a stick on the, it's just like a mitral clip for the tricuspid valve. It's a bearing for the tricuspid valve. I mean, it's really good because you can put a bigger size ring and put a clover technique, and the valve are usually counted later on really good. They don't have much gradient. So I really experienced that. So that's what I would consider. And that's considered treatment.
I mean, that's what we do, what we try and do when we do triplet. We try and reproduce the clover. And that's why we will flip anteroseptal and posteroseptal to try and recreate that. Right.
You've done this, yeah.
Yeah.
And so the estimated mortality, because of the clinical assessment, the patient is good, you wouldn't say the chance of dying more than 5%.
What was it? Mortality?
I think that's right. To the group patients, I do not think it. And there is a new publication from STS, which we saw that the surgical research for outcome after tricuspid valve procedures, that all the complications, they were really showing bad outcome, by almost 50% mortality rate, especially for really cases. But this is the new publication that's probably the last couple of years showing much better outcome with tricuspid valve procedure in the recent era. With that being said, anyway, one thing I really more fundamental is make sure that you prepare the patient for the procedure. And I remember one of the patients who was over 8 years old or interventionals tried to play couldn't keep the patient. I mean, they put a couple of clips on it and still stayed traditional PR. And that was some kind of patient with, I would say, ordinary pressure. So that we did, a medical patient to the hospital, she stayed in the unit 2 weeks on the intermediate care. We prepared the patient, made sure that everything is like in the right way. Once she was like the right time, we operated on her, she was very well, and she was discharged home. But again, it depends.
I think we had, going more to, yes, we call it now, we always talk about, rehab afterwards, the rehab, and working with, we've done this as well. I mean, I remember I sent the patient to Sasha, who was able to have the patient drop their weight 120 pounds in 2 weeks. If you remember that, Sasha, when big happens. But this is it, I mean, this paper is recent, right? I mean, this is a greatest paper from 2 years ago, right? So this is based on more recent data, and I mean, Dreyfus is one of the fantastic surgeons in the world. So this is him saying when these things look bad or not in mind.
Okay, and yeah, said the patient the lead to put in that.
I'm sorry, I was gonna just ask 2 quick questions. One is,
Wait for the mic.
2 quick questions, just like valve money. This is a tremendous amount of TR, that you see after this from the pacemaker lead. And it's not a primary artery myopathy.
If you put a pin in that question,
Yeah.
you will get the answer.
Okay, and the second question is, I don't know how much you look at the hemodynamics with these things outside of the echo, but the PAPI and all that stuff is probably a little bit low for RV function and the cardiac index as well.
I think that's a key point, right? The RA pressure is 15. Was it higher than the wet, or was it almost the same?
15 and 17.
15 and 17. So great. So I think let's see what happens, and the discussion will remain open.
One more point. That
score calculation, it's a demand calculation. That kind to say, you get 2 points of having high validity. And with the patient, we have the patient, got everyone is appear, worse will be better.
Yeah.
Okay, it's a benign person.
So let's see what happens.
Yeah, that's a great point. And I agree with the comments about the RV dysfunction. Normally, these patients in our valve clinic, we do multi-parametric 3D TTE and TE to look at them, and it's not like severe dysfunction. So we did have this patient evaluated by EP actually for lead extraction, because we want to see if it was going to be an option, because then maybe it actually opens up some of our treatment options that are right now we're thinking are not so feasible or much higher risk because of the presence of the lead. We weren't really expecting the TR to necessarily go away because we know there's lots of tethering. So there's a significant functional component. But if there is a component that's coming from the lead and then lead extraction is reasonably safe, that's often something that we'll at least think about, because the other, potential benefit would be, well, if we can maybe improve the coaptation just a little bit, what if he kind of remodels in the right way and maybe the annulus gets slightly smaller and now he actually sizes in for devices. So he was evaluated by our lead extractor here, and had that done with no complications, fortunately. But as we sort of expected, he still has significant leaflet tethering, still terrible TR, all across the valve in terms of that tethering, anterior and posterior. And then we repeated his CT, and unfortunately, his annulus is exactly the same size. So really, unfortunately, not significantly changed. We did have it officially evaluated from an evoke point of view. And because normally we want a little bit of oversizing for stability, they actually calculated a little bit of undersizing. So it was a clear kind of no from a safety point of view, just for device stability.
Yeah, so
now
we have removed the lead, so you don't have to do that anymore. That's gone. And now the currently available, this is the live situation. Now the currently available graph is too small. And I'm going to also talk about the last. Okay, so that's where we are right now. And now, unfortunately, the patient is in good condition. The patient has not been hospitalized. Okay, the patient was not for the anatomy, would be anti-trial. Right, so now the patient is asking me, do I have to fix this? He's feeling okay. He's not an edema. He has no IR-15. He's 9, I think.
Or 9, yeah.
Normal. And there's a very, I looked for a scientific with ultrasound, there's more scientific, and delivered to the amount. 1.5 induction probably has some fibrosis, which you would be. So now the question for me is, and this I saw him yesterday, to say, we have to keep this. You do surgery. You say it's not 22%, but maybe it's 8 to 10%.
What are you trying to do?
What are
you trying to fix?
Well, right.
Guys, is asymptomatic.
78.
He's not hospitalized.
That's great.
73, he's not hospitalized.
Yeah.
Right here. You're not showing any cubic survival, or you get admission for heart failure.
Yes, we had compensated a little bit about 6 months ago, and then we cleaned up. He's done now.
And he's asking if we're going to use this.
Yeah.
He's not saying, please do something.
Yeah.
You're operating on an amplifier.
Right.
But the clinical imperative, the driving surgery.
So I tell you what I told him. Let's just get updated with all the info about the other options.
Yeah, sure.
Yeah? And then I tell you what we'll do. We'll see. I'm not sure what's the answer.
Yeah, so it's still kind of an open question. I mean, we haven't treated this patient yet. We had them evaluated for some of the other kind of large annulus options from a transcatheter point of view, just from a minimally invasive, at least to see what those options were. This is a valve that actually comes from a company in China called the Lux valve. Originally, it was implanted transatrially, and then they converted it to a transcatheter solution that's actually transjugular, which is interesting. And there have been a number of implants, including compassionate use cases in the US and 2 that we've actually done at MonteHeart. So it's not that unlike the other valves that, we've seen that, double frame kind of design. What's unique about this valve is the anchoring mechanism, which is this ventricular anchor. It's pretty low profile. It just kind of has a little grapple hook that basically sticks into the ventricular septum. And then there's 2 little tabs laterally. And then when we had him evaluated just to see by CT, since he had it already, is this an option? So he does actually anatomically meet criteria to have a successful implant with the Lux.
So he had some heart failure, he had no clinical heart failure about 6 months ago, I think, something like that, it's still doesn't. And the diabetic requirement at that point. I did not consider an option of a repair that we described. For me, I was just thinking the stuff, either a 30 stuff or a surgical stuff, which, based on the data, even if it's a 10% mortality, is not a joke. So I believe that, this is some other data that's about to come out on the movement study that I'm working on. So I believe that the early identifier of decline was a worsening of the brain function, a worsening of the bilirubin. And what I told him is, we have been stable right now. I see a signal of that, and if you don't have the percutaneous valve, then and only then, and not to wait too long, we can decide pretty safely walking around with the temporal effect here. This is pretty good out. And I said, if I see any warning signs there, then we have to make a decision whether you want to be outcome based on surgery. I don't think it's perfect because it's liver function, these guys, basically. So that's why I'm honestly not sure.
Also, one thing is, management is not a job more than people, right? To really extraction.
I don't think the severity increased. I think we see the jet a lot clearer without the lead being there, but the underlying mechanism didn't really change. And there wasn't any obvious sort of subvalvular valve apparatus damage from that extraction, fortunately.
The only thing is, if you operate on that patient, you operate in this field. The problem is, you'll be admitted with ascites and adding on contract. That's why the problem is, the guidelines is, a lot of people point out that even if you have statements, you are down the road to you'll private to start. So that may be the other point. It has some arguments of writing us again down the road. You won't be that 85 another point.
Yeah, I completely agree. That's why I'm happy, that's why I pulled everybody to the table for this case. The other thing that I learned, which I didn't realize before, our age 15, I can make it stuff, no big deal. I'm pretty sure I exercised this patient, put this one in, and then assessed, CVP. 21, 30, I guess.
Yeah, because they already
Yeah.
annual.
And so we underestimate what we need to breaking. So I'm not sure what to do with it. That's what I told you yesterday. The last valve, I think you're going to speak to the FDA next week or something. No,
we can get it within 2 months.
Okay, that's off the press. So I think that would be my recommendation to them. It's an unclear, I don't really want to weigh in. It's unclear. I'm reluctant to recommend surgery for this.
How sure we are that this likes to work without.
It's a great question. So probably about 300 cases down in China, 100 cases down in Europe, in multiple centers. And 30 compassionate use cases in the US, including 2 we've done before. I did 2 cases on one day, and the second case was 40 minutes. 40 minutes we're done getting patients without. And that's interesting. The results have been really good. Short term, it is an example of the case, one of the cases we did. Very low pacemaker rates, very soft implant and with anchors. We don't know the long term.
I mean, because it just hasn't been around for that long, so we know the bench date and the duplicated data because they need that for the FDA approval. But we don't know the rest. And so right now, there'll be an early feasibility study in the US, probably starting in December, maybe January, we want to do it about.
Yeah. So we appeal to FDA for compassionate use.
So we just, I mean, this, the FDA doesn't mind being on compassionate use, they want to do it and study, but I actually have to tell you that I saw China food today, and I asked him about his patient, and he said, you can go with patient come first.
Right. That's the final statement for the day. Patients come first. So thanks everybody for staying late. And we'll do tomorrow at 8 o'clock. Yeah. Thanks. Thank you.
For kids, yeah, I think there's one. They made it for Microsoft. There's no micro. You guys have Sasha, how do you decide which accent is which? It didn't sound like German accent. I know. What's German accent? You know what's Dominican? You know what's German? I was from Europe. They think you know German. Are you this is really you're going back to middle class. I'm like, you guys put the mic for yes, we have to. Yes.
Okay, so
You're gonna join us for dinner, yeah?
Sure.
Yeah.
I'll be happy. He's driving me there, so. Yeah.
Okay, great. He drives a German car, so you'll be
Oh,
fine.
yeah. I was told that there is a bunch of German cars. I have the advantage of selecting which one I want.
Yeah.
Porsche versus BMW.
Look, this is going to be
And then this is for this case, for example.
so where do you want the question? So this is the first case. Should this be the question?
This is the first one, yeah.
Okay, and then you have. Here is the case. So you're gonna present the case, and then this is gonna be the.
That will be exactly. That will be the second case, and this is
I cannot write the whole case there. Yet.
No.
You'll be talking about the case, and then when this comes, then name them so that people have time, and then just slide over, and then.
So how is that? I will slide.
Yeah, so basically you'll go to the right. So with your hand, you go to the right with three fingers.
And then the people can
vote in real time.
All right. And then there's the third one.
Let's do three. Yeah.
Yeah.
We can do three.
And that's the third one. And then the answer for the first case will show up at the end. So
Will
this
show
is
up for you. Yeah, you have control over that. I won't show it. Okay.
Great video.
Thank you very much. Appreciate that. Thank you.
And remember to delete
Let's
one.
delete it now.
Yeah.
Okay. All right. I'll see you at dinner.
See you.
All right.
Yeah.
Take care. See you guys. Take care.
You go to the dinner?
Yeah, you too, right?
Yes.
Okay.
So I'll meet you there.
Okay.
I'm not gonna have a beer, but
Why not? You don't call?
no, I like some other drinks.
Other drink. Curious to know. Vodka?
No, but, yeah,
Vodka.
grappa, you know.
Oh, yeah.
Okay.
Yeah.
Let's just. move to the-
And thank you, Ben. Thank you so much.
Of course. What is in there?
No,
I didn't expect you.
some
to
of the no,
Don't ask.
no, some of the image have copyright.
Oh, yeah.
They remove here, then they post it online.
Who knows? Yeah.
Who knows?
Yeah.
And then you are responsible of the
Oh, yeah,
of copyright.
It's true.
I've seen a guy